It's
Very good.
summertime, so it's beautiful.
Brilliant.
And
Mehmet,
winter will probably start in about a month. It'll be cold by the end of September, but um, I'm actually going to Cleveland in a couple weeks. Uh, go visit everybody.
good. I think we do miss you in our live session, so hopefully we'll have you over soon.
Yeah, not working much anymore, so it's easy.
Good. So Luis Baba has joined us as well, and Ramin, our host, is here as well. So I think let's start.
Yes, sir. Thank you, everyone. Greetings and welcome to day one of WFNS Young Neurosurgeon Neurotrauma Conference 2025. I'm Dr. Ramin Fasal Jalani. I'm resident of neurosurgery from Pakistan. So now, without further ado, let's start our conference with the opening remarks from Dr. Najia Alabadi, Dr. Sabina Ludri, and Dr. Luis Borba. If you guys can unmute yourselves.
Can we start with Luis then, please?
Yes, sure. Thank you, Dr. Luis. The floor is yours.
Hello, everyone. Good morning. Can you listen me?
Yes, we can hear you.
Yes. Okay. Okay. Oh, Sabino, how are you?
Hello, President. Everything okay? Miss you so much.
Okay.
See you soon.
First of all, I'd like to congratulate
Thank
the
you.
wonderful job of Professor Salman and all these people is doing, Sabino and all this young generation that is coming in neurosurgery. World Federation is education. Education, our main goals. And we believe that if this job that Salma is doing and the next will continue, will make the difference. Now you are getting more and more neurosurgeons involved in education around the world. And I strongly believe that this is the way to improve the neurosurgery and give the education to all corners of this world. Thank you, all of you, the work as you are doing, the time that you are taking to help and to improve the neurosurgery around the world. I'll be here listening you and listen all the participants in this meeting. Thank you, Sabino. Thank you, my friend Salman Sharif. The tireless Salman Sharif. Thank you. Bye.
Thank you, Luis. I must confess that besides me, the most important figure that has helped us all along is Mehmet Zalili, who's here as well. And he's just worked nonstop for the Dubai meeting and this meeting as well, and I'm grateful.
I didn't see him because, sorry. And Professor Tariq Khan also.
And Tariq Khan is here as well.
I'm trying to. I'm on the phone here.
And Carl Roster has joined us as well.
Where is these
besides-
big people? Oh, now everybody. I can see everyone here. Hello. Professor Hosler, pleasure to meet you.
Yes, thank you. Fine. It's also a great pleasure for me to contribute again.
Great. Mehmet. Thank you. Sorry.
Okay, off we go. Thank you, Luis. Where is our friend gone? Maybe we get Sabino to say a few words first.
Yes, thank you so much for this kind invitation and distinguished and dear Mr. President, colleagues and respected faculty and all my young neurosurgical friends. It is a true honor to welcome all of you to this WFNS, Young Neurosurgeon Neurotrauma Conference. This is a beautiful event that, all my friends arranged all together. We know very well that neurotrauma remains one of the greatest global challenges in neurosurgery, and every day millions of patients are affected from this trauma, and often we are the first responders as young neurosurgeons, residents, trainees, and who stand from the front line of this care. So it's the topic, it's so important, and it's so inspiring. And let me tell you also that what inspires me in every event is not only the knowledge we will share together, from advances in neurotrauma and pediatric care, especially, that are the main topics of this conference, but it is also the goal to innovate the approach in research and technology that, will be highlighted in this beautiful event that all my friends arranged here. Honestly and humbly, I encourage from my side all young colleagues to be proactive and to engage with mentors and the giants that are involved in this beautiful meeting, to use this opportunity to shape their careers. Remember that the future of neurosurgery is already in our hands, especially in your hands as young neurosurgeon, and every abstract presented here, and every question, and every quiz, and every collaboration here bring us all, closer to safer and more effective care for our patients. So my few words on behalf of WFNS Young Neurosurgery Committee. I thank you all once again, all the organizers, moderation, and speaker, and let us to continue to build together across borders and across disciplines, across everything, the future of neurosurgery. Thank you so much for being here.
Thank you, Sabino. I think I'll just ask Mehmet to say a few words before we ask our other friend to speak.
Yeah, thank you, Salman. Yeah, this is the second great Zoom conference we are having with your leadership. And it's really a big event. Everything are online, so it's very comfortable for many of us. And it's good that many young neurosurgeons are also involved in these conferences. I'm grateful to all the speakers and all the participants coming here with us. Thank you. Thank you, all the organizers.
Okay. Thank you, Dr. Mehmet. Thank you, Dr. Sabina. Now, moving on to our first session of this conference, we have the Young Neurosurgeon session, which is going to be moderated by Dr. Asad Abbas and Dr. Mirna Sovana. So please, guys, if you can open up your mics and start the moderation of the next session.
Good evening.
Hi, good afternoon, everyone. Thank you very much. I'm just going to call up on the next speaker without further ado. It's going to be Daniel Santos, who will present on lumbar ischemic spondylolisthesis, comparative insights into patient selection, surgical technique, and clinical outcomes. Dr. Daniel Santos, please.
Just request to all the speakers, please stick to time, because otherwise, everybody else gets delayed, and it's everybody on Saturday and Sunday helping us. So please stick to time.
Right, a moment, please. I try to share my screen. Can you see my screen?
Yes.
Yeah, we can.
Hi, everyone. My name is Daniel Encarnacion, and I'm from Dominican Republic. And thank you for allowing me to present my strategy. Lumbar ischemic spondylolisthesis, comparative insight into patient selection, surgical technique, clinical outcomes. What we need to know, like lumbar ischemic spondylolisthesis. Lumbar ischemic spondylolisthesis often results from the line spondylosis is a prevalent cause of chronic lumbar pain and radiculopathy. And these studies aim to compare one stage versus two stages and approaches in patients grade 1 to 4 and spondylolisthesis, with a focus on functional outcome, complication rate, and sagittal alignments. Okay, we had a retrospective observation study was conducted in 80 patients, 49 women and 31 men, the age 18 to 89 years old, and diagnosed with spondylolisthesis, spondylosis and spondylolisthesis. The patient was stratified into 4 groups, 1A, 1B, 2A, 2B, based on the grades and the surgical strategy, single stage or 2 stages. The surgical intervention including transforaminal interbody fusion to lift, minimally invasive missed lift, posterior lobar interbody diffusion, belief with descompression, interbody diffusion using autograft and cages. The outcome was examined using the Frank scale, Carlock index, and echo hood performance status. And the result, we divide this group in 2 groups, the patients, we divide the patient in 2 groups. And group 1 has spondylolisthesis grades 1 and 2, when a stable spinal motion, variable discomfort from light radiculopathy. In the patient group 2, grades 3 and 4, the sagittal alignment was restored in most cases. In the group 1B, extended lift, so complete balance restoration. In the group 1A, 2 stages, sustained correction with minimal complication, 3 to 71%. Compared ese group en 2B, consider the compression, correction, y stabilization. And you can see the distribution of the patient on the 3 scale divided into the patient. When we mentioned before that the 1A, 3 to 5, 75% complication rate, and 2A, just 5% complication rates. In this graph, we can combine the group with percent of the patient and number of the patient.
Last 2 seconds.
And the same like the Frank scale, Carlock index, and the echo group scale. We had, for example, a case. Okay, we have case 6 years. Yellow female with bilateral ischemic spondylolisthesis, with chronic lobar pain related to the left, and diagnosed with grade 1 spondylolisthesis with bilateral part defect and the level LPI sedent. In conclusion, one study is affected in low grade. When surgery preferred in advanced cases with neurological compromise in the body fusion, the sign enhance the sagittal alignment functional outcome. Thank you for your attention.
Thank you.
And the next speaker would be Dr. Seris Altaf. He will present predicting post-resection persistent hydrocephalus in pediatric patient with posterior fossa tumors using Canadian preoperative prediction rule for hydrocephalus, CPPRH scale. You have 3 minutes to present. Please, Dr. Seris.
Hello, Assalamu alaikum. Hello.
Walaikum salam.
Hello, good afternoon, everyone. I'm Dr. Seris Altaf from Hamdard University Hospital. I'm working as Senior Registrar in Neurosurgery. And I have the privilege today to present on the topic that is predicting post-resection persistent hydrocephalus in pediatric patients with posterior fossa tumors using modified Canadian preoperative prediction rule for the hydrocephalus CPPRH scale. So as we all know that the posterior fossa neoplasms are the most prevalent neoplasms in the pediatric patients, and these tumors lie in the close vicinity of the fourth ventricle. So the main controversy is whether to treat the hydrocephalus before the primary tumor resection, since the prophylactic CSF diversion procedures may expose about 70% of the individuals to the unnecessary risk. And the CPPRH scale was developed in an attempt to categorize these patients based on their likelihood of experiencing the post-operative hydrocephalus following the removal of the posterior fossa tumor. So this is the modified CPPRH scale, which includes the age less than 2 years, points given is 3. Presence of transependymal edema, moderate or severe hydrocephalus, cerebral metastasis, again, the score will be given as 3. And preoperative estimated tumor diagnosis given the score 1 each. So the total possible scoring will be 10. So we included the patients with less than 18 years of age with new radiologically confirmed diagnosis of posterior neoplasm and who subsequently underwent resection were included, while the patients who undergone this pre-operate resection, treatment, permanent case of divergence previously, and the patients with pre-existing hydrocephalus or the patients whose data were lost were not included, and those patients who died within the 6 months of tumor resections were not included. We divided the patients into 2 categories, that is low risk with a score 0 to 4 and the high risk with a score between 5 to 10. The patients were followed for next 6 months, and so this was our result. Our result showed that the patients with the CPPRH high scale, that is 31.3% of the patients, most of the patients, that is 28.4% of the patients, needed the post-resection CSF diversion, while the patients with the CPPRH low risk, that is a score with the 0 to 4, only 6.8% patients needed post-resection CSF diversion. So this was our result, and so we concluded that the CSF shunts are associated with the, as we all know, myriad of potential complications and can lead to upward herniation or intratumoral hemorrhage in case of posterior fossa tumor. So the CPPRH is a valuable tool, and its main purpose is to separate the patients into high and low risk groups in order to aid in the patient counseling, customize our treatment plans according to the CPPRH scale, and to adjust the level of post-operative hydrocephalus monitoring, and to prevent the patient from unnecessary shunt dependency and unnecessary shunt-related complications. Thank you.
Thank you very much for sticking to the. Can I please request Sayeda Arisha Shakil to present on frequency of brain injuries and associated cervical spine injuries in a tertiary care hospital in lower middle income country? Dr. Arisha Shakil, please. Would you please stick to 3 minutes time? Thank you.
Can you guys see my screen?
Yeah.
Okay. So I'm going to present a frequency of brain injuries and associated cervical injuries in a tertiary care hospital in lower to middle income countries. Traumatic brain injuries are leading cause of so traumatic brain injuries are a leading cause of morbidity and mortality worldwide, particularly in low and middle income countries like Pakistan due to high rates of road traffic accidents. Cervical spine injuries may coexist with TBIs and are often undiagnosed, especially in resource limited setting. The objective of my study was to determine the frequency and patterns of head injuries and associated cervical spine injuries in trauma patients which were admitted to a tertiary care hospital in Pakistan. So this is a retrospective cohort prevalence study. It is ongoing. The data I'm going to present is from January to June of this year in the Department of Neurosurgery, Liaquat National Hospital. So we have seen 184 trauma patients which have been admitted in our care, and the demographics, mechanism of injury, type of brain injury, GCS, and these things are seen. The study included 79.9% males and 20.1% females, and most injuries were due to road traffic accidents. The common head injuries were contusions, which were 32.4%, subdural hematomas were 29.4%, EDH and subarachnoid hemorrhage each were 15.3%, skull fractures were 20.6%, lacerations simply were 8.8%, and diffuse axonal injuries were 6.5%. The associated spinal injuries so far that we have seen are 2.9%, and the most common level which has been involved is C5 level. 32.9% of the patients were managed by surgery, and 67.1% had conservative management. On discharge, around 69.3% had a GCS of 15 over 15. GOS Glasgow Outcome Scale showed good recovery in 140 patients, moderate disability in 20, severe in 15, and neurovegetative state in 2.4%, and there was death in 3 patients. In conclusion, road traffic accidents are the leading cause of TBIs, although less common. Cervical spine injury are clinically significant. Routine cervical evaluation is essential in all head trauma cases. Thank you.
Thank you, Dr. Sida Arista. The next will be Dr. Chayo Eduardo Rodriguez Falcao. The title is Geriatric Traumatic Brain Injury Increasing in Brazil, 2008 until 2024. You have 3 minutes to present, please,
Can you listen?
Dr. Eduardo.
Okay, can you listen?
Yes, good.
Okay, perfect. Can you see the
Please.
screen?
Yes.
Okay,
Yes.
perfect. Hello everyone, my name is Caio, I'm from Brazil, and today I'll be presenting our study titled Direct Traumatic Brain Injury Increase in Brazil. First of all, I would like to sincerely and thank you, Dr. Robson Morin, for his invaluable mentorship and guidance in this project. First of all, we have to know that the proportion of TBI among elder population is expected to increase in coming decades, but the majority of data about geriatric TBI were restricted to developing countries. In this context, the present study aimed to identify time trends about deaths and hospitalizations of geriatric TBI in Brazil. We had three main hypotheses. The first hypothesis was that the increase of geriatric TBI will follow the trend of population age. The second one is, as we have more healthcare infrastructure, the in-hospital mortality wouldn't increase. And the third one, as Brazil is a continental country, would be regional disparity, with north and northwest regions more effective because these regions are more affected by regional disparities. Our first hypothesis was confirmed, and we had upward trend in all regions of Brazil, and Brazil was general, as seen in this graphic. So our first hypothesis was confirmed, but our second one wasn't. We expect that the mortality rate wouldn't rise, but in Brazil, over the 6th period, we analyzed the mortality rate also increased with an upward trend in all regions of Brazil. And our last hypothesis was confirmed, partly confirmed, because we expect there was regional disparities between the region of Brazil, but wasn't the northeast, was the southeast. And this is a unique pattern because in other diseases that are studied in Brazil, northeast, southeast is not usually the most effective in any disease, but in geriatric TBI, southeast was the most effective. So in conclusion, our study demonstrated the rising burden of geriatric TBI in Brazil and highlights the urgent need for a specific prevention strategies and a more rational structured trauma care system. Thank you.
Thank you very much, Kyle. Now I would like to invite Dr. B.R. Kinzaglu. He will present on soleus nerve transfer to tibialis anterior, effective treatment for proximal common peroneal nerve injuries. Dr. Kinzaglu.
Yeah, hello everyone. Hope you're doing well, guys. Let me share the screen. Yeah. Okay. Common peroneal nerve injuries among most prevalent neuropathies, accounting for 40% of cases. I'm so sorry. Of knee trauma cases based on retrospective clinical studies. Injury for peroneal portion of sciatic nerve also occurs during hip arthroplasty and other proximal sciatic nerve injuries. This injury typically results in foot drop due to impaired ankle dorsiflexion. And despite advances in peripheral nerve surgery, existing interventions for foot drop, such as tendon transfer or nerve grafts, often demonstrate suboptimal functional outcomes with high rates of residual disability of because of long distance between the location of injury to the target muscle. Considering all the disadvantages of these methods, we suggest using nerve transfers. On this slide, you can see the main steps of the surgery. First of all, approach. I prefer using posterior approach in these cases. Despite many works, I believe that posterior approach is much more convenient and allows for better outcomes in dissection, for better dissection. Secondly, it is important to pay attention to intraneural dissection. Before reaching the fibula head, the peroneal nerve has 3 portions, and I will not elaborate on all of them, but we have to pay attention, have to focus on the medial portion, medial one, which innervates the tibialis anterior and extends the hallucis longus muscle. And you need to dissect it properly, guided by the principle donor distal, recipient proximal. And then you can take the soleus branch of tibialis and transfer it to the medial portion of peroneal. Our results on the screen we retrospectively analyze the outcomes of 14 patients with follow-up 12 months, and in 64% of patients we can see really good outcomes, good recovery with M4 and M3 after 12 months. Unfortunately, there are also poor results, most commonly observed in patients over 60-year-old, and apparently associated with neuroplasticity, with bad neuroplasticity. So soleus to deep peroneal nerve transfer achieved functional dorsiflexion in more than 60% of cases, enabling independent ambulation without orthotic devices. This technique represents a viable alternative to traditional methods, particularly in patients with proximal CPM lesions unsuitable for direct repair. Thank you for your attention, and thanks for invitation. Yeah.
Thank you, Dr. Kinziaglov. The next speaker would be Dr. Majdolin Barkatse. The title would be Advances in Liquid Biopsy for Monitoring Glioma Progression and Treatment Response. You have 3 minutes to present. Please, Dr. Majdolin. Dr. Barkatse, are you here? Dr. Barkatse, are you here?
Yes, she's here.
If she's not here, and then the next speaker will be Dr. Billy Benedict, minimally invasive spine surgery for lumbar disc herniation, a systematic review and meta-analysis. You have 3 minutes to present. Please, Dr. Billy. Dr. Benedict, Dr. Billy Benedict, are you here? I guess
yes, he's here. He's here, he's hearing.
Hello. Sorry, ma. The host disabled the function, so I was not able to switch on the camera. Neither was I able to switch on the audio. So perhaps I could then
you can share
try
now.
to
You can share now.
the slide because it's. Thank you. Just a second, so I could share. Is it visible?
Yes, it's all good. You may full screen your presentation.
Okay, sorry. I'm trying to also switch on the camera, and so is everything fine now? Are you able to see me, and is the presentation visible? Hello?
It's visible. It's visible, but it's not full screen yet. You make.
Is it on my side? It is. Sorry for that. Okay.
It's okay. You can present as it is.
As it
you
is.
can see your slides.
Isn't this for full screen?
It's okay. It's fine.
Okay, thank you. My name is Billy McBenedict, and I'll be presenting a meta-analysis on minimally invasive spine surgery for lumbar disc herniation. And I'm grateful to the team for the wonderful work. Lumbar disc herniation is a major cause for sciatica, and microdiscectomy is a gold standard technique. Percutaneous transforaminal endoscopic discectomy and microendoscopic discectomy are largely used. However, the comparative safety and efficacy remain debated across centers. Therefore, the objective of this study was clear: to compare the safety and efficacy profiles of PTED, MED, and using high-quality RCT evidence.
Your screen is not moving. It's still in the topic.
Sorry, I really think there could be something that's happening. Did you enable my, I don't know, perhaps, because could somebody perhaps direct me what to do? Because I am presenting, but stop share. You
We've
can see.
gone to key results. You can see your key results now. So you can present your results and go to conclusion. It's all right.
But that would affect my delivery of the message. My apologies. So my name is Billy McBenedict. I'll be presenting a meta-analysis on the minimally invasive spine surgery for lumbar disc herniation. And I'm grateful to the team for the input. Lumbar disc herniation is a major cause of sciatica, and LDH and microdiscectomy is the gold standard technique. Percutaneous transforaminal endoscopic discectomy and microendoscopic discectomy are largely utilized. However, the problem is that the comparative safety and efficacy remain debated, and the main objective was to compare the safety and efficacy profiles of PTD, MED, and MD using high-quality RCT evidence. We screened more than 2,300 records using PRISMA guidelines. We retrieved 48 RCTs with 7,651 patients, and regarding complications, PTED had the lowest infection rates. Regarding dural tears, PTED had the lowest again, and regarding dysphagia, PTED had the lowest. For nerve injuries, they were comparable. Regarding functional outcomes, the hospital stay in particular, PTED reduced the duration to 3.5 days. For functional outcomes, they were all similar. The take-home message is that PTED offers the best safety and fast recovery. Thank you.
Thank you very much. I think we have now got Dr. Marjolaine Barcake joining us, and they will present on advances in liquid biopsy for monitoring glioma progression and treatment response.
Hello, can you speak?
Are you here, Marjolaine? Marjolaine, are you here?
Unmute, but
I think she's dropped out.
so, Dr. Hassan, maybe you can ask questions to the presenters if you want.
Okay. Imad, in the meantime, we can ask questions and maybe we can check if this person is ready there or not.
From the attendees, thank you very much for the presentation. Are there any burning questions that you can take in the next couple of minutes? You can either type in the chat box or unmute yourself.
I think we can move on to the next session then.
Okay, looks like there are no questions. Well, I would like to thank all the presenters who presented their great work today, and would like to conclude today's abstract session, and we'll head on to the next session. Thank you very much, everyone.
Thank you very much. Thank you very much, Dr. Asad.
Who are the moderators for this session? Do we have the moderators for this session, please? Unmute yourself. Kazadi got stuck with a case, so he may be late. Bonsing and Mona, please join.
Yes. Dr. Bonseng and Dr. Mona have joined us.
Yeah. So we can start our session now, Prof.
Sure, please start.
Yeah, okay. Good morning and good evening to all. Now we are going for the second session. We will alternate introduce our speaker until our Professor Kazadi join us. So it give me a great honor to invite Professor Tariq Khan, who is a professor and head of Department of Neurosurgery at the Northwest General Hospital Research Center, Peshawar, Pakistan. And he will present to us on traumatic brain injury for 10 minutes presentation. Let's welcome Professor Tariq Khan.
Thank you. Can you see my screen and hear me?
Yes, Professor.
Okay. First of all, thanks to the young neurosurgeons for organizing this amazing meeting. And thank you, Salman. Thank you, Mehmet. And of course, thanks very much to Imad. So basically, I'm going to talk not about management. I'm going to talk about policy because I believe policy is a domain of neurosurgeons, especially policy for neurosurgery. And what I'm going to talk about is recognizing traumatic brain injury as chronic and notifiable condition. And this is a resolution we're trying to move in the World Health Assembly. So it started off with me anyway, with this paper came out from Pakistan in 2023, an official paper regarding the state of health in Pakistan as provinces and territories in 2023. And it talked about the global burden of disease study. And looking at the paper, there was no mention about traumatic brain injury, either in mortality or morbidity. And this started me thinking, and I had a discussion with certain people like Tony Fegacci. And if you look at this document as well, it also does not show in the top 10 diseases anything about traumatic brain injury. But of course, we know that it is different if you look at all over lower and middle income countries. If you look at the motorbikes and if you look at all this, it's very obvious that, and from all the papers which we see, we say that the traumatic brain injury is the most common killer, more mortality than malaria and HIV together now. So obviously it's very important, but all the data we have is extrapolated data. It is not any data which really has been from any place. The only place we know which is collecting data is in Australia. But we know that although it is the leading cause of death, despite this, it is underdiagnosed, underreported, and underprioritized because it is not there in the national health data systems. And we know that without mandatory notification, health system cannot accurately measure or respond to the true burden of traumatic brain injury. We also know that there's evidence that long-term neurorehabilitation and patient narratives show that TBI survivors suffer from cognitive decline, depression, personality changes, and many other problems with their family or caregivers. So declaring traumatic brain injury as chronic realigns health systems to track, support, and rehabilitate survivors far beyond the acute emergency phase. So it's obvious that early data plus notification is better prevention than care. Real-time surveillance is required. Identification of hotspots and high-risk groups is required. Informed allocation of health resources is required. Ultimately, this would lead to smarter investment, improved, reduced long-term problems in the health system. Because there is lack of follow-up care, data visibility, and support, TBI without notification is invisible in policy, which would mean it is neglected. So as I said, the only country is Australia and a few states in the United States, like New Mexico, which are making it notifiable. What would a World Health Assembly resolution on TBI as notifiable and chronic condition achieve? And this is what we are trying to do. It's because a World Health resolution would place TBI formally on the global health agenda, send a signal that TBI matters and that it is a public health priority. It would correct a long-standing policy blind spot. And that would help in early intervention, smarter resource allocation, targeted prevention strategies. It helps quantify and visualize the true burden of traumatic brain injury, especially in lower and middle income countries. So we need to get it classified and so that we can integrate traumatic brain injury into a notifiable disease list to improve real-time data collection, just like reporting infectious diseases. And this resolution will provide a legitimized framework for Ministry of Health to act and implement reforms. It will give access to technical guidance from World Health Organization. It would align donors. It would have potential for inclusion in World Bank and UNDP health portfolios so that there is more investment. And it will encourage countries to involve people with lived experience in helping them and recognize survivor-led storytelling and advocacy as key to driving political will. So, although it's difficult, but it demands a sustained political and diplomatic commitment, but so did past global successes as well, like polio eradication. So we know that it is important, and we know that what gets counted gets funded, and what gets funded gets fixed. So it will become from an invisible crisis into a trackable, fundable, and manageable global health condition. So we started with all these points, engaging with policymakers, building a coalition, and we have made, we started with 2-3 people, and now we have more than 100 organizations who are supporting this program, and we are hoping that we are able to go to the World Health Assembly next year. The Minister of Health, Pakistan, formally agreed to sponsor the resolution, and very, very hopeful now that Central African Republic, Qatar, Ecuador, Tanzania, Ethiopia, Indonesia are going to be helping us in that. The draft resolution has already been prepared. As a traumatic brain injury is a distinct global health priority, notifiable, chronic, and preventable. And we know that the World Health Assembly is meeting in May next year, and we hope that we can try and get the resolution there. This was a very successful meeting which we had in Geneva in May on the sidelines of the World Health Assembly, which was very successful. And there were many stakeholders, not only neurosurgeons, but from all areas, all walks of life. And this was last week when we met with the Health Minister of Indonesia, who agreed to sponsor the resolution as well. And hopefully we'll have now more than one country sponsoring this resolution. We have upcoming advocacy events in Cairo, which we are going to be attending with the help of Program of Global Surgery and Social Change. Then we have an UN General Assembly event in September, where we're going to be working. Then we have the Western Pacific meeting in Fiji. And then, of course, the WFNS meeting in Dubai. And we would request all of you young and senior neurosurgeons, whoever want to be part of this struggle, kindly connect to me so that we can move this thing forward. Thank you so much. Thank you very much.
Thank you. Thank you, Professor, for a very concise and important message to all of us. We are looking for a question in the chat box. We still have probably about 2 minutes. Maybe I will start by asking Professor two questions, Professor. Do you think that the emphasis on a mild head injury, which I think also did contribute to some cognitive impairment and do cause a poor performance of a patient to return to work, do you think the current return to work and compensation mechanism is good enough for those patients, Professor?
No, not at all. That's why there were two things. We talked about collecting data of all head injuries, anybody coming into ER with a traumatic brain injury, and we have started a pilot project between Cambridge and Northwest School of Medicine in Peshawar to collect all the data. Also, we are talking about persons with lived experience so that they know and that we want it to become a chronic condition, so that it can be looked at and that proper management, compensation aside, I think the management to be able to, first of all, diagnose and realize that this patient has got a chronic injury, and then moving on to compensation, of course. Thank you very much.
Thank you, Prof. I don't see any further question. We would like to thank Prof as usual, and hopefully Professor Tariq and the team would continue bringing this important message to the World Health Organization and become a priority in the organization. Thank you, Professor.
Thank you, with your help.
Thank you, Professor. I pass the session to Mona to introduce our second speaker. Mona.
Yes, hello everybody. First, I would thank Professor Sharif and all the committee of the WFNS Young Neurosurgeon Neurotrauma Conference invitation for the kind invitation, and I send you all my great love and consideration from Tunisia. I will ask Professor Jack Morcos if he is here to join us. Professor Marcos is head of neurosurgical department in Houston and expert in neurovascular surgery, cavernomas, fistulas, bypass.
Sorry, Dr. Mona.
Yes.
Dr.
I think you need to move on to the next speaker.
Okay. So I'll introduce. I'm honored to introduce Professor Karl Rossler from Austria, head of the neurosurgical department of Vienna, and expert in epilepsy surgery. More than 450 publications about this subject. So thank you for being with us, Professor Rossler, and come on.
Yeah, thank you very much, Mona, for the invitation. Thanks all the participants. I'm honored to give this lecture. It's about what's new in epilepsy surgery. I have nothing to declare. There are mainly 4 groups of different kind of procedures. It's invasive diagnostics, resective surgery, disconnective surgery, and stimulation procedures. But I will start with the pre-surgical evaluation advances. There is an ILE paper about early referral. It's very important. Patients younger than 70 years with drug-resistant epilepsy after 2 appropriate anti-seizure medications should be referred for surgical evaluation. This is still under used, and the ILE wants to and is going to reduce this gap. Pre-surgical imaging. There are some advances like the harness protocol. You should look up this, but in the clinics there is now more and more coming in the 7 Tesla MRI imaging. There are several groups working on it. The results are that in 50% there are additional findings, in about 20% there are new lesions which you cannot find in a 1.5 or 3 Tesla MRI. There is another important AI-related radiomics approach, which means you use AI for detecting lesions which you can't see on conventional MRI images. This is especially the MELT protocol, which is available in the internet. You can load it down and you can use it. It's basically free, and you can detect like focal cortical dysplasias for surgical resection. Another maybe old method, it's called ASL, arterial spin labeling. It's used for epilepsy detection of lesions, and it seems to work quite well. I would recommend you to have a look at these publications. Invasive monitoring, there is a trend that SEG, which means step electrode implantation, is now substituting the former grid and strip monitoring, which had to be done by large craniotomies. And it's because patients are feeling more well after depth electrodes implantation, and there are less complications. And you also have with these depth electrodes a tool where you can coagulate with radiofrequency spiking electrodes. There's also a new technique, it's called cortical evoked potentials. It's for detecting epileptic zones. We are stimulating and registering electrocortical potentials. What's new in surgery, ablation, and disconnection? You have this old concept, the zone concept by Lüders and et al., which is the basis for the resective surgery. The resective surgery has several strategies like lesionectomies, extended lesionectomies, tailored resections by using electrocorticography, selective lesionectomies, partial lobectomies, and multilobectomies. And this resective concept, it has a very high success rate in epilepsy surgery. Like in mesiotemporal sclerosis, nearly 80% seizure-free patient. This was a study of us in Erlangen, which we published a few years ago. There is another study which I wanted to introduce you. It's very new from a Japan group. It's about high seizure-free patients after extended lesionectomies in long-term epilepsy-associated tumors, or like in FCDs, the resection concept has proved to be a very successfully about 80% seizure-free patients. And what's new in surgical resections? One new trend is to use augmented reality for surgical resections, where you introduce lesion contours into your operating microscope and also use navigated instruments to detect lesion borders. It looks like this. Here's a surgery of a focal cortical dysplasia. The suction tip is navigated, and you see the 3-plane MRIs where the suction tip is working on which part of, on which sulcus, on which part of the brain, so that you can orientate yourself during the surgery by using this augmented reality concept. But of course, there are not only lesional, focal lesional epilepsies. There is the network concept. Epilepsy basically is a network disease, and there are all kind of disconnective and ablative epilepsy surgical procedures to address this network concept, like the laser ablation. Basically, you are using a laser fiber to target superficially or deep-seated targets like focal cortical dysplasias or hypothalamic hamartomas or even small cavernomas to ablate these lesions through very small boreholes. We in Vienna, we adapted a whole operating room for doing that kind of procedures where the operating table is next to an intraoperative MRI facility so that you don't have to move the patients through floors so that you can do the procedure within the same OR. In the United States, lid ablations have reached the number one for performing also mesial temporal lobe epilepsies. The outcomes approaching nearly the resective surgical results. What's new in hemispheric disconnective procedures? Hemispherotomies for catastrophic epilepsies like Rasmussen's or post-stroke hemispheric epilepsies have become minimal invasive. There are used endoscope, radiofrequency ablations, and lid hemispherotomies for performing these disconnection procedures. We have just published this case for minimal invasive open surgical disconnection for a hemispherotomy. In insular epilepsy techniques, as you can see in this systematic review meta-analysis, open surgery is still the gold standard for the epilepsy in insular cases. Neuromodulation, the oldest neuromodulation approach is the vagus nerve stimulation. It's around about more than 30 years, but it's still a gold standard for generalized epilepsy and with very good results. You can see here a very recent paper on it. Basically, nearly all patients are profiting from this kind of stimulation procedures, especially children. The DBS for epilepsy surgery is also still a gold standard for generalized epilepsy, like enterothalamic stimulation as proved in the Santé study 15 years ago, but there are still new data which show that in 75% of the patients with generalized epilepsy, patients profit from this kind of stimulation approach. There is the responsive neurostimulation, the closed loop stimulation, which can be used also for hippocampal stimulation, like Arthur Kukiat demonstrated this in a prospective study, and it's a very good option for dominant mesial temporal lobe epilepsy, where you have to be considered to preserve the memory. And for deep brain stimulation in epilepsy, there are new targets, especially in the thalamus. Additionally to the anterior nucleus, you have the central median and the pulvina for getting good results with this kind of technique. And RNS is also more and more used with promising results for thalamic DBS. So my key messages for epilepsy centers is screen for drug-resistant epilepsy and refer early, run cases through multidisciplinary surgical conferences, introduce new imaging modalities like 7 Tesla, AI radiomics, or arterial spin labeling, introduce augmented reality support, lid ablations or minimal invasive techniques for hemispherotomy, and offer neuromodulation for non-resectable or multifocal cases. and consider new targets in DBS for epilepsy like hippocampus, central median, or pulvinar. So with that, I thank you for your attention and wish further a nice conference.
This very clear and someone has confidence for novel techniques of imaging epilepsy.
Excellent talk, Carl. Really impressive. Just a question. Is there a difference between the age group, pediatric and adult, when you're treating this?
The main difference is that
Dr. Sharif.
The main difference is that in older ages, in the adults, you have more lesionectomies, and in children, you have to do disconnections very, very early. In very severe epilepsies, you have to do hemispherotomies, you have to do callosotomies, you have to do disconnection procedures. This is the main difference.
And you think stimulation is really the future from here on, or lit will take over?
Stimulation is a very important field. It's developing, new targets are arriving, and I think it has a brilliant future, but I think ablation, disconnection, and resection strategies are still to be preserved and will be still important in the future.
Excellent talk, and really impressive, especially for young people. Any further questions, Mona, Benson? Sabino, do you have any questions?
No questions for me. Really impressive.
Maybe one question from me, Professor. You mentioned 7 Tesla MRI, and most of the time that with current 1.5 or 3 Tesla, sometimes we cannot identify any focal lesion in epilepsy study. So what is the relevant and the future of 7 Tesla MRI in management of epilepsy, especially drug resistant? Thank you, Professor.
I think 7 Tesla MRI will come more and more into the clinical setting, and not only our group, but also many groups have shown that you really find new lesions in up to 20% of the MRI negative cases. So you can basically confine your ultra high field investigations with 7 Tesla on MRI negative epilepsies. It makes no sense to investigate lesional cases.
Thank you very much, Professor. Mona?
Yes, we move to the next presentation with.
Let's just check who's here, because we are way ahead of time. So I think we just need to check if our friends are here, because we are about 40 minutes ahead of time.
Mm-hmm. So next speaker is Professor Zanchen.
Emad, do we have Zenchen here? Can you please see if Zenchen and Roger, I'll just check.
Professor Roger Harter is there?
He's not here yet.
Yes. Is Professor Giuseppe Cinelli here?
No, he's got stuck in an island where the Wi-Fi wasn't working. So he tried, but his connection was disconnecting. So he called me. So we can't get through. So in the meantime, I think we'll get Professor Rosler to tell us more about epilepsy surgery. And I think, for me, the main problem is when we do MRI and we don't find a lesion, and we know it is coming from a certain area, then how do we go about it? What do you do then?
First, we try to use advanced imaging like as we already have talked about, 7 Tesla MRI, but there's also these AI tools and radiomic tools like MELD imaging, where you compare your patient with a high number of standard MRIs, and it shows you the differences in certain areas. Other strategies, imaging strategies are PET imaging, positron and emission tomography, which maybe shows an hypo or hyper metabolism in areas where some MRI negative lesions could be. And if you don't find anything in the imaging and you have a good idea that maybe the epilepsy comes from a certain lobe or 1 or 2 lobes like temporal or insular or frontal, you can use depth electrodes, which means you implant the patient and you do a multi-day video EEG monitorings with these depth electrodes. And if you find some spiking areas when he appears to have seizures, you can resect according to the electrophysiological results of the depth electrodes.
Okay, any more questions?
Maybe one more question from me, Professor, if you allow. Professor, I would like to know regarding SEEG. As far as I understand, is very much depend on the surgeon in determining the end location of your SEEG lead in most cases. Is there any attempt in the future or near future to collect those data regarding the location of the SEEG probe in all those cases worldwide to some form of creating a mapping, at least a best guess from the big data in terms of detecting abnormal electrical activity with SEEG, Professor? Thank you.
I think this would be a wonderful idea and a wonderful project to collect all these kind of EEG data and to use AI to maybe find some hotspot areas. But as you know, the problem, the epileptogenic zones are pretty much individualized. You would maybe find some areas with which are more prone to generate epilepsy, but for the individual patient, it is very important to have a seizure conference and to discuss the patient with your epileptologists, radiologists, neuropsychologists, and all the people who are dealing with the patient to define where to implant the electrodes. So we don't decide the implantation by us, by the neurosurgeons. We are deciding the implantation location according to the discussion with our epileptologists and all the physicians involved in the patient.
Maybe one more question, Professor. In your patient who have been treated for epilepsy and cured, how many of them we actually have this burden of normality? Would you have such a problem within your patient, and how do you deal with them? Thank you, Professor.
I didn't get the question exactly.
Burden of normality mean they're out of seizure. Now they are less cared because there are no more seizure. Family support are less. So we have this kind of emotional support, which are now getting away from them. Do you have such problem with your patient, and how do you deal with them? Thank you, Professor.
Yeah, the problem is the more chronic the epilepsy is, the longer the patient suffers from the epilepsy. He has a social economical burden, which means he's in most times very isolated and very anxious, and very determined by his disease. So if the epilepsy stops, you have to support him to find into the normal life. And this is maybe much more difficult than as neurosurgical procedure to stop the epilepsy. This is a very important point which you raised.
Thank you,
Hi.
Professor.
Somebody has posted a question regarding the importance of magnetoencephalography scan in diagnostics and management. Thank you.
The MRI is one of the
MEG.
MEG. MEGs are not so widespread available, but they have a very good three-dimensional resolution in detecting epileptogenic regions. So I worked for 8 years. I worked in Erlangen together with Stefan Ramp. He's the guy who runs the MEG there, and he has analyzed more than 1,000 cases of these MEGs in epilepsy patients. And I think on a few hundreds where we did the resections, the best results were when we resected the MEG focus. So MEGs are very cost intensive to run, and they are very expensive to buy. So there are not so many around.
Mona, there's a question from the audience. Would you like to read to the professor?
Okay, I think.
Professor,
No, thank you.
Sorry, I think what we will do is that I've asked Mehmet to give a 10-minute talk, and I've got Sabino to give a 10-minute talk because our friends are delayed. They won't be here within this time. So Sabino is looking into his computer as you see him, and Mehmet is looking into his computer as we go on. In the meantime, we'll ask Tariq Khan question about what does he see the future from here on. Mehmet is actually joined, but we'll take this question.
I'm ready.
Okay, just this question for Tariq, and then we come to you.
Sure. I believe if we are lucky, we'll be able to get the resolution passed from the World Health Assembly this year, and then the real work will start to convince the governments to start and make it notifiable. But if it is done, you will be talking about huge difference in prevention, getting funding for that, which is very important, then getting funding for pre-hospital care and acute care, of course, and then rehab as well. So I think we need all of us need to get together, not only neurosurgeons, but everybody across the board. Thank you.
Totally agree. Mona, you want to introduce Ma'am Azarili, although he doesn't need an introduction, please.
Thank you, Professor Mohammed Zilili, for being here. So we are very honored to have you. Please come on and share your screen with the audience.
Thanks a lot. It is a great honor for me to have a talk like this. I will talk about the differential diagnosis of back pain. This is, as you know, a great part of our daily practice is with back pain patients. We are full with back pain patients. If you look at these films, this is a 62 years old female patient with a low back pain for 30 years, right leg pain for 6 months, and the radiology shows that there is an L5S1 isthmic dystasis. And many of you would think that that right leg pain comes from that isthmic dystasis and would like to screw up L5S1 screw together with the posterolateral or interbody fusion. But on examination, she had sacroiliac joint pain, and she responded a test injection and her pain completely relieved by radiofrequency lesion of right sacroiliac joint. So there was no need for any surgery. This is one of the greatest problems, that the identification of the source of pain in degenerative spinal disorders is difficult, and incidental radiologic pathology and back pain and leg pain are common. If we look at the incidence of spinal disorders, there are many non-specific disorders like low back pain, neck pain, 85 to 90%. However, specific disorders are 10 to 15% of our practice. And pain in spinal disorders may have different origins, like disc, weak and stretched muscles, lumbosacral ligaments, facet joints, and we then use a very unique or interesting terminology: discogenic pain, myofascial pain, facet pain, central pain, radicular pain, such awkward terminology. In general, there are two types of pain. One is the nociceptive, and the other one is neuropathic pain. And the axial pain and radicular pain are most of the nociceptive pain, and axial pain is more common than radicular pain. Another issue is that if a pain has a chronic manner, then there are many other symptoms like non-restorative sleep, low energy level, depression, psychological effects, and we need a multidisciplinary approach to relieve a chronic pain than an acute pain. So the question is how to evaluate pain in spinal disorders. History taking is important, yes. Observing physical exam, neurologic exam, then the radiology. And by history taking, we can understand many types of pain. For instance, discogenic pain will have morning stiffness and more pain on sitting, and standing up from sitting position is painful. However, facet joint pain will have pain aggravated on extension of the back, and the symptoms are also unique. There are certain questions to look for the claudication and other types. And pain with fever and weight loss, pain with lying at night, morning stiffness, mechanical pain. These characteristics are very important to decide the origin of the pain. We must also observe the patient during walking. Neurologic exam is necessary, but not the sole exam. And it is, I believe, it is too much stress in the residency programs, and we must learn how to examine a patient, especially in the elderly. Yeah, I will skip. I mentioned that already. In the physical exam, we must palpate the painful area. Let the patient flex and extend the body. Passive movements of the neck and back. Limited signs of leg pain during back extension, which is a synonym of the cervical extension, pain on cervical extension. Sacroiliac joint pain can be understood by palpation of the joint. Pain is mostly asymmetric, and provocation tests are positive. We must apply them. Somebody reports that it is the source of pain in 25% of all back pain patients. This is a very high incidence. These are the tests that we can apply to understand sacroiliac joint pain. facet pain is sitting is comfortable. However, extension and rotation is painful, and the patients try to become kyphotic posture. In acute pain, mostly after intense exercise or heavy lifting, sitting and standing are painful, flexion is painful, and trigger points may be found. It is very, very common. And however, chronic pain, we call if a low back pain lasts more than 3 months with intense, then as I mentioned before, there are certain other findings, and the dealing with such pain are more complex and need a multidisciplinary approach. We must also know the red flags in low back pain patients. If there are red flags, then we can order radiologic tests. However, if there is no red flag, ordering a radiologic test is not much necessary. Although best test is MRI, there is very, very bad correlation with radiology and degenerative spine symptoms. And we know that radiologists report lumbar disc herniation in 25% of normal population. So if our cascade is like this, we are having immediate radiology for a low back pain patient, and very commonly they are having reports of disc herniation, then we are doing some surgeries and no pain relief. So this is not a good cascade. But certainly I'm seeing in the practice we are making such diagnostic mistakes in the daily practice. We must repeat the sentence, operate the patient, not the films. And the estimated number of MR images in the United States only because of low back pain in a year, 3,800,000 is that much big. A group of people have done a comparative study. In one group, they have applied MR images and looked at the immediate MR images, and then looked at the consequences of the back pain. In the other group, they didn't apply immediate MR image if there is no red flag sign. So they have compared both groups and then found that there is no difference in the outcomes or the effect of the treatment in any group. So the application of less is more for low back pain must be applied. What about the value of other diagnostic tests other than radiology? Electrophysiology, you can ask. Yes, there are certain indications, but there is no good test measuring pain. We must know that. And electrophysiology results depends on what test you are doing. If there is a suspicion of polyneuropathy, ALS, cauda equina syndrome, foot drop without pain, follow-up of a foot drop, then you can order EMG and nerve conduction study. Otherwise, it is useless and it causes new question marks on your mind. So in my practice, I believe we must not order EMG or nerve conduction study in lumbar disc herniation, cervical disc herniation, cervical spondylotic myelopathy, and lumbar spine stenosis patients. I will skip some of the slides and then come to the conclusion. Pain is the main problem in degenerative spine disorders. Evaluation of the pain is not easy. Worse correlation between pain and radiology. And pain is polluted by many factors, And most of the spine disorders are non-specific, back pain, leg pain, or low back pain. We must learn that operate the patient, not the films, must be our logo. And seniors must make clinic and patient evaluation examination with juniors to teach them nicely. And I also invite you to look at the WFNS education.org website and to see all the webinars. Also, the previous Young Neurosurgeons Forum talks are all there. Thank you.
Thank you, Mehmet. Wonderful talk. I think this is the gist of day-to-day work that we do all the time, and we misdiagnose seeing what's in front of us. Mona and Bunseng.
Thank you, Dr. Zileli. It is always very interesting to listen to you. We were very honored to receive you many times in Tunisia, and every time it was very rich, and you have all our respect from Tunisia. It was very clear, and it's very important to know which is the source of the pain, and to ensure that the surgery is very well planned. I don't have questions, but if someone have a question to ask to Professor Zileli.
I think Professor Roger Hartle is here. So if you could invite, please.
Yeah, hi. Thank you so much. I hope I'm not late. I thought I was early.
You are early. It's fine. You're early.
Good. I had a question for Dr. Zileli. Can I ask a question?
Sure.
Yes, of course.
SI joint pain, in your experience, how often is it that patient with SI joint pain actually needs surgery? Because it's very interesting, because there are some practices where this is being done fairly commonly, and then others who never really see this as a surgical indication. But in your experience, how often do patients end up needing surgery for SI joint related pain issues?
You mean SI joint fusion surgery?
Yeah, SI joint.
Okay. In fact, I don't believe it's very necessary to make an SI joint fusion. I have not much experience on that, but I am quite satisfied with the SI joint injections.
Yeah.
So probably somebody who are doing such surgeries must answer that question. I have no experience with this.
Okay.
Yeah, I'm satisfied with injections.
Yeah, same here. I think it requires you need to do SI joint fusion maybe once in a year kind of thing. It's very, very rare. Majority of the time, SI joint injections, if it's continuously bothering them, or radiofrequency lesioning does the trick. And really, it's very rare. But yes, you're right that since it's MIS and it's quick, many people do a 15-minute surgery for these patients.
Yeah, that's the background, because in North America, it's not that uncommon, but it's regional, And I've never done it. I've never really seen it as a necessity, but I was just wondering, like, internationally, how that is being viewed. That's why I was asking.
Yeah. This is probably a local problem of US.
Maybe.
Roger, you want to go next?
Yeah, of course. Thank you. Yeah, I'll share my slides. And can you see this? So I was asked to talk about updates or what's new in MISS, so minimally invasive spinal surgery. And this is obviously, it depends on, it's a very kind of personal opinion, because it depends on your practice, kind of what you're doing. But so I'm going to give you a little bit of an overview. These are my disclosures. So MISS, minimally invasive spine surgery. I had the good fortune of working with the AO MIS task force, and this picture kind of summarizes. MISS is heavily driven by technology, by industry, by all types of competitive, techniques. Tubular surgery, percutaneous screws, robotics, augmented reality, virtual reality, lateral surgery, anterior, posterior tubular endoscopy. It's quite heavy on industry and technology. So, and obviously there's always a lot of new kind of technology that comes out, but it is important to remember that the goal, at the end of the day, the goal is obviously to have a good patient outcome and to reduce. And for MISS specifically, the goal is to reduce local operative tissue damage and systemic surgical stress to ultimately achieve better patient outcomes. And I think for many, especially degenerative spinal problems, we actually are pretty good at achieving that nowadays. And a lot of it is due to new technology. Now, in the task force, when we teach MISS, we kind of refer to these 6 T's. The first one is target, which is patient selection, which is really the most important. And what's new in patient selection? I mean, there's not much really new in patient selection, but I think what will have a big impact, and I'm not going to talk about that, but I think AI is going to have a big impact on patient selection and decision making in surgery, right? I'm not going to talk about that, but I just want to mention that. The news that I will kind of talk about are really more in terms of tools, technology, and techniques. So those are the other T's. And then teaching, training. There's actually a lot of new developments with teaching and training, especially with surgical simulation. We just did a course last week in New York using these surgical models. There are different companies that make those that you can use to treat lumbar spinal stenosis, spondylolisthesis, using regular instruments that you use in the OR. But instead of cadavers, you use surgical models. And I think that's news. I mean, that's pretty amazing. And we've shown over the years that you can actually really use these models to improve surgical skills in trainees. So let's talk a little bit more about tools, technology, and surgical techniques and what's new in that regard. We call that enabling technologies, right? Tubology is tubular surgery in North America, specular surgery maybe more in Europe, but operating through tubes, right? That's something that we've been doing for a while. And there are more and more data coming out that compared to open surgery, there's really a benefit. Endoscopy is a little bit of a competitive way of doing decompression surgery, and I'll share some thoughts about that. In terms of putting in pedicle screw percutaneously with navigation, there's new technology out there. I'm going to share that with you. I'll talk a little bit about augmented reality, expandable cages for MIS surgery. So expandable cages, I'm a big TLIF guy, so I do a lot of surgery from the back. So I'll talk a little bit about putting in expandable cages from the back through a TLIF approach. And then biologics, we're not going to talk a lot about biologics, but I want to point your attention to regeneration and repair. There's a lot of data coming out for disc repair, disc regeneration, and it's quite interesting. Now, enabling technologies in spine, if you look at the complexity of surgery and invasiveness, the MIS benefit zone here, in my opinion, those are cases that entail 2, 3, 4 level decompression cases or fusion cases. So I think for the simple complexity cases, a microdiscectomy, whether you do that with the endoscope, with a tube, or with traditional open surgery, is no big change. Same with very complex deformity. But I think once you start treating 2, 3, 4 level degenerative cases, either with a decompression or with a fusion, that's really where MIS kind of shines. And navigation, robotics, augmented reality are really applicable over the whole spectrum of spine surgery nowadays. This is very different from 10, 15 years ago. Microscope and tubular surgery for everything that requires a decompression or where you have to remove the joint to put a cage in, like TLIF procedures. Tubular surgery with microscopic magnification, in my opinion, is still a great way of doing it. There are exoscopes out there. There are other ways to visualize, magnify, illuminate the pathology. in my opinion, the operating microscope is still unmatched because of the quality of the image that you get, the three-dimensional aspects, and just the magnification. Endoscopy, definitely very, very exciting, but has a very limited spectrum. You know, it's for microdiscectomy, for endoscopic decompression, endoscopic fusion surgery. I think quite controversial. And I don't know if that's ever going to expand to the more complex pathologies endoscopy. So you end up learning something for a long time because the learning curve is challenging. And then you can only apply it to a small spectrum of surgical indications. So you got to keep that in mind. And then lateral surgery is very exciting when it comes to, prone lateral in North America, prone lateral fusion. I don't do those, but I understand that this is a very exciting field. I'm worried about vascular injuries and so forth, but there are surgeons who are really good with lateral and prone lateral surgery. And then expandable technologies, expandable cages. So we're going to talk about some of those. Tubular surgery, we kind of summarize the pros and cons and the ins and outs and tips and tricks for tubular decompression surgery in the lumbar and also in the cervical spine. For me, that's really the workhorse. I do most of my cases with tubular surgery. And I think it's a great way of doing it. When it comes to fusion, I use tubes, but I could do that in combination with cages and screws, screw placement. There are the 7 lifts, right? The A lift, the O lift, the L lift, which is like the X lift on the prone lateral surgery. Then the transforaminal lumbar interbody fusion, removing the facet joint, and then a variation going a little bit more lateral, keeping most of the facet joint intact and putting in the cage, avoiding the spinal canal and putting in the cage that way. These are, for me, really the most common lumbar fusion procedures. The PLIF surgery is usually open surgery. Sometimes I do that as well, but it's more like an open procedure, of course. Now, a lot of this has been summarized with the MIS task force, and I think that it is worthwhile to look at that for those of you who are young surgeons. A lot of surgeons use the AO surgery reference for the trauma classification because it has an excellent module to classify fractures, of course, but we also have all of the MIS material now for endoscopic and tubular decompression and fusion surgery on AO surgery reference. So if you're interested, you can download this app. It's for free, and it gives you a great update. What are the big categories in the future for minimally invasive spine surgery? Well, this is kind of a parallel to orthopedic surgery, but also biologics. So biologics to enhance fusion, but also biologics to enhance disc regeneration, disc repair are going to be very important. The whole issue of AI, augmented reality, virtual reality for diagnostic purposes, very, very important. And then finally, intraoperative imaging for navigation and for robotic surgery. So I think those are the 3 big categories that are going to penetrate spine surgery more and more. And in North America and the US, there's a huge shift from inpatient spine surgery to outpatient ambulatory spine surgery. Has a lot of implications for payers, for reimbursement, and so forth. So these technological advances allow us to really shift patients from inpatient to outpatient surgery. That's why we pay a lot of advantage to that, pay a lot of attention to this. Now, tubular surgery compared to open surgery, of course, you keep a lot of the stabilizing aspects of the spine intact. There's less fusion surgery when you're very, very good with tubular decompression surgery. Infection risk is lower, bleeding is lower. And there are more and more data really showing that decompression of lumbar spinal stenosis through a tubular retractor is more effective and safer. This is a meta-analysis that we just submitted for publication, looking at 10 studies with almost 3,000 patients comparing open laminectomy to tubular laminectomy. And the results really show in this study, again, this has not been published yet, we just submitted this, but tubular MIS surgery reduces complications, blood loss, infection, and length of stay. And therefore, you can expand your indications to a certain extent. You can operate patients who are a little bit older, maybe a little bit more fragile, that you otherwise may not have operated on with open surgery. So there's a lot of advantage to tubular surgery. In my practice, what tubular surgery really means that I can avoid fusion surgery. And I really, and for me, that's great news, because instead of doing fusion on everybody who has lumbar spondylolisthesis, in those patients who have a stable spondy without mechanical back pain, I will do a decompression without a fusion. Intraforaminal soft pathology, like an intraforaminal disc herniation, sometimes also just canal, foraminal stenosis, I will decompress with a tubular retractor, just like you would with the endoscope. You come in from the side with a 15 mm tubular retractor. You can see the DRG, you can decompress it very, very safely. So no fusion surgery necessary. If I have a patient who has multi-level lumbar stenosis, where one level is spondylolisthetic and needs a fusion, I will do a fusion at the level that has spondylolisthesis, and an MIS decompression without fusion at the level above or below. So I can save that patient a multi-level fusion and only fuse one level where the patient actually has instability. And then most synovial cysts I'll decompress without doing a fusion. Now, for me, MISS really means minimal and measured instrumentation surgery. So minimally invasive spine surgery, to me, through tubular retractors, really means minimal and measured instrumentation surgery. So you avoid the need for fusion. What about endoscopy? Endoscopy, I mentioned it before, it's a great technology, and I would encourage young surgeons to learn it. I tried it. I found it a little bit difficult, and I just favor the tubes. But it is expensive. It's heavily industry driven. You can do tubular surgery by cutting syringes. This is a picture from Mexico. We did surgeries in Mexico, and there, the surgeons cut the syringes and do tubular surgery through syringes. However, ideally, you need a microscope, which is the downside of tubular surgery. Endoscopic surgery, a little bit challenging. Learning curve, it takes longer. Most things take longer in endoscopy than with open or tubular surgery. I'm always worried about the DRG with transforaminal endoscopic surgery. There's a real risk of injury to the DRG, which can result in a painful complication. And then obviously it's expensive, because especially for the uniportal endoscopy, you need the tower and all that. And then my criticism of endoscopy really refers to the fact that it's one-handed surgery. For a microsurgeon, you want to work with two hands, and the tubes allow you to work with two hands. It's 3D magnification through the microscope. Is a broad indication. With endoscope, it's more narrow. So again, I know that there's a lot of enthusiasm about endoscopic surgery, but that's why I wanted to mention it here, because I think you really got to be a little bit critical and kind of see where that whole thing goes with endoscopic surgery. On the other hand, I'm very excited about navigation. I think navigation is here to stay. It has shown to enhance the safety of surgery, the precision of placement of screw placement. And you're going to keep in mind that navigation includes augmented reality, virtual reality, freehand navigation, and robotics. So all these work together. You can't just look at those in isolation. If you want to take advantage of navigation, you got to really look at the whole spectrum of navigation. This is a typical case when we put in MIS pedicle screw through a small incision from the back with freehand navigation, and we use a single step. We only use, and the different companies make these types of implants now, where instead of navigating the K-wire, the awl, the tip, and then the screw, you only navigate one instrument. So that really makes the workflow so much easier, and really makes it so much more workflow related, so much more beneficial to just navigate one instrument rather than navigating multiple instruments for navigation. And we looked at the accuracy, which was very, very high, 95% accuracy of percutaneous pedicle screws, single step pedicle screws placed with freehand navigation. Augmented reality is something that really penetrates our whole life these days. What about surgery? Augmented reality. There are two ways of utilizing augmented reality. One is with the goggles, where you put in pedicle screws, and in the goggles you kind of see the anatomy and put in your pedicle screws that way. I'm really more interested in augmented reality, how it augments your workflow. So not only for the pedicle screws, but then also once you do your microsurgical decompression, the augmented reality showing you certain landmarks that you feed into your view to be able then to find certain landmarks. We did that very effectively for MIS TLIF surgery, where we visualize the pedicles, the disc space, the facet joint, and sequentially play those landmarks into the operative view through the microscope and guide surgeons through the whole TLIF operation. Just as an example, we use TLIF, but you could really use any other operation as well. We did this in a study together with Claudius Tomé in Innsbruck, where we had 12 surgeons do MIS TLIF surgery. This is looking at the skin, and you can see here the pedicles that are relevant for the TLIF surgery, the facet joint, the disc space, and basically you put in your tubular retractor, and then while you're doing the approach and then the decompression, the augmented reality kind of shows you exactly what are the relevant landmarks for your operation. Now this is putting the dilator, and this is now removing the facet joint. We're drilling from the transition between the spinous process and the lamina to the pars, and then we remove the IAP, and the blue line here is the facet joint. This is just an example of how you can use the augmented reality not only to put in screws, but also to guide you through the operation. And we did this with Claudius Tomé in a study in Innsbruck in New York, and using augmented reality in young surgeons to have them do MIS TLIF surgery 3 times in a row in the model, we found that augmented reality led to less mental demand and cognitive load in these surgeons and better overall performance. And finally, just a few words about expandable cages here. We use expandable cages for MIS TLIF surgery here, and you can see with expandable cages, you can restore segmental lordosis in MIS TLIF surgery, which is quite important because the general kind of criticism of MIS TLIF surgery is that you cannot really affect lordosis that much. But I think with expandable cages, as long as you're very careful and you avoid overexpansion and subsidence, you can really use this technology to effectively restore lordosis. So anyway, I think I'm pretty much at the end. So enabling technologies, we talked about tubology, endoscopy, single-step pedicle screws, augmented reality, expandable cages. I didn't talk about biologics, but I just want to remind you that at the end of the day, obviously, patient selection is really the most important thing. No matter how much technology you use, you got to pick the right operation for the right indication. That's the most important thing. But if you have a surgical plan and you're convinced that that's the correct surgical plan, if you can do this with advanced technology, I think then that it's certainly a good thing, and obviously it has to be cost effective as well. So thank you for your attention. If you want to learn more about MIS, come to New York in December 12th and 13th. We have a big course in New York. We're partnering with the Seattle Science Foundation, and we'll welcome you there to learn about MIS. Thank you so much, Salman and Mehmet and everybody else, and Muna. And I hope that this was adequate. Thank you.
Thank you, Professor Hazel, for this excellent presentation. I agree with you that to open surgery, but I have a little question. Have you had any failure in with tubular surgery for distal herniation? If there are cases, what was the reason for conversion to open surgery? Was there an error in some patient or hemorrhagic accident?
Yeah, I'm just thinking, I've done tubular surgery for 20 years, and I started almost 20 years ago. I got to tell you, I don't think I converted once. I remember I converted once because of a CSF leak, intraoperative CSF leak, because I had to bring the patient back later. because I just couldn't, but other than that, I don't remember really ever converting. I mean, it's really once you put your tubular retractor, once you're there, it's really like open surgery. There's no big difference, and I would recommend surgeons who are not that familiar, maybe start with a bigger tube, take a lot of time with the exposure, maybe use navigation if you have navigation available, because it can be confusing, So if you have navigation available, maybe do your first cases with tubular surgery with navigation, so you kind of keep your orientation. But I don't, I think the conversion rate generally is very, very low.
I think I agree, Roger.
Okay, thank
I think
you.
everybody has the same experience. Sorry, I think I'm going to just request Sabino, who stepped in and would give a 10-minute talk to us on Salar anatomy and his journey there. Roger, excellent. We are grateful. Please stay with us so that we can have your company during the research session.
Thank you.
Should I share my screen, Salman?
Yes, please.
Okay, thank you so much. Okay, this is an off program just to fill the gap, and I will talk about, my humble experience and just to overview, and that could be, useful for a young neurosurgeon about some concept in terms of transcranial approaches to the sellar and parasellar area. And this topic could be useful also if you consider that, traumatic brain injury sometimes involve the anterior middle skull base. You know very well that anterior middle skull base, it's, from the anatomical point of view, is a challenging region. And you have to take in mind that, lots of lesion can involve especially the sellar and parasellar area. And when we talk about skull-based approaches, the magic and the basic principle is always the same. So remove the bone to leave the brain alone, as Professor Amefti say, one of my mentors. And this critical concept to classify it in your mind, what is which are the corridors in the anterior, middle, and posterior skull base in terms of median, paramedian, and lateral corridors also. And when we talk about, skull base, especially sellar and parasellar area, you have to consider that most of the lesion can involve also a neighboring region like, pterygoid fossa, parapharyngeal space, mandibular, infratemporal fossa, and so on. And this is an overview of the, neighboring region that we can deal with this kind of surgery when we talk about transcranial approaches with sellar and parasellar region. Nobody can argue against the usefulness of endoscopic surgery today, and everybody knows very well these main corridors to the anterior and middle skull base, especially at the level of the sellar and parasellar area, and these are the main steps. But nobody can argue about the fact that the advent of the nasoseptal that flap totally revolutionized this kind of surgery. But still today there are some indication for transcranial approaches that I'm gonna talking about. And in transsphenoidal, as you see here, it is beautiful because you have lots of corridors, suprasellar corridor, suprachiasmatic, infrachiasmatic, and whatever you want. But I don't want to take too much time to talk about all the flexibility of this kind of endoscopic approach to the median parasellar region. But I just want to focus once again about the concept that in this, type of skull-based lesion, you have 3 different corridors, and for sure there is no, and the main principle is the fact that you can reach with endoscopic approach the median, paramedian corridor that lies on the same way, but it's really difficult to reach the lateral skull-based surgery when we talk about, sellar and parasellar region. Conversely, with transcranial approach, you can reach lateral, paramedian, and even median corridor. This is one of the most important advantage in the transcranial related to the transcranial approaches to the skull base. You have to have clear in mind there's some classification, and this is an overview of the classification that I summarize in a book that we recently published with our group. And also there are some pictures because especially for young neurosurgeons that start to do this kind of surgery, you have to perfectly know this kind of anatomy, special ICA, because very few people knows the details of ICA and collaterals. And this is an overview of the paramedian skull base and all the corridors that are some doors that you can use to enter this kind of skull base, a medial skull base. Some of them, especially Dolen-Akuba corridor, are very, very important and useful to reach this kind of lesion. And don't forget that when we deal with this kind of lesion, this lesion usually can involve different neighboring space, not only sellar and parasellar region, but during their growing, they can involve also anterior cranial fossa, middle cranial fossa, and even, retrosellar space, petroclival junction, and all these regions. But this is the key, slides of my presentation about the indication of transcranial approaches for giant, for example, pituitary adenoma in endoscopic area. This is maybe could sound some anachronistic view, but this is everything but anachronistic, because we recently, in a paper that we published with one of my mentor, Professor Mefti, we summarized, those factors that are related to the individual anatomical variability of the sellar and parasellar area that we have to take into account even in the endoscopic era. And these kind of factors are namely pneumatization of the sphenoid sinus that sometimes can be a contraindication to endoscopic skull base surgery, angiomorphology of the internal carotid arteries, dimensions of the sellar, vascular pattern of the intercavernous sinuses, and especially anatomy of the sellar diaphragm, because sometimes you can have some diaphragmatic constriction that can limit your corridor during, endoscopic transnasal approach. And everybody knows the fact that with transcranial approach, pterional, and the addictive variation of the pterional approach like COZ and similar, you can have three different corridors. The first one is the transsylvian, and then the second one is the subfrontal, and then the third most useful one is the pretemporal corridor, that is beautiful corridor to the parasellar area and space. And you have to keep in mind that all of these corridors correspond to precise and well-defined intradural corridors that are some, routes to reach our targets. And especially because we can reach even the retrosellar space through these deep windows, and some of them are related to transsylvian perspectives, and other of them are related to pretemporal perspectives. This is the main contribution that Professor Dolenk maybe gave to all of us, to skull-based surgery, and this is the Dolenk-Akuba approach to the parasellar area. That is a workhorse that I want to summarize in 7 steps for young neurosurgeon. The first step, before to start this step, one of the most important aspects is to perform the CSF release. And don't forget that you don't need any lumbar drainage here to withdraw any CSF, because you have the trigeminal system here that you can open to withdraw the CSF and to, work in a so-called leakic brain. And then don't forget never that is a beautiful anatomy that you have to keep in mind, like anterior, medial, and lateral loop of the ICA. That's the reason why I told you, especially my take-home message to young neurosurgeons, you have to keep in mind and to know perfectly the anatomy of the ICA, especially the cavernous carotid and the paraclinoidal carotid here. And when you think about this kind of lesion, you have to take in mind that you have different pattern of growth. Some lesion can be, in the medial, posterior to the medial loop. Some lesion can grow anterior to the medial loop. And some lesion can grow, medial to the medial loop. And these are, the so-called, also you work in so-called carotid collar here, and carotid collar is the, marks the limits of the ICA in terms of proximal and distal dural ring, and you have an interdural space here that you have to keep in mind when you think about the growing pattern of the lesion that involve this kind of space, especially meningioma, but also Meckel's trigeminal schwannoma. In terms of Dolenk approach, that is the workhorse of the paracells transcranial approach to the parasellar area, you have a step 1. The step 1 is directed to the contralateral sellar area here, and you work exactly at the level of the interdural space in between the distal and proximal dural ring. The 7 steps of this approach is, directed to the ipsilateral sellar area and carotid sinus and cavernous sinus here, and you are working still at the level of the interdural space. After that, you have to keep in mind that you can turn the table to perform these two very, very different kind of step, and you know, work in 180 degrees toward this kind of target. And in doing this, the extension of the head is one of the most important key points to reach this lesion, especially when they have a very huge supradiaphragmatic extension, like we saw in this picture. And then we have a step 3. The step 3 is carried out through the so-called supratrochlear triangle. Here, you work in a very narrow space to remove that part of lesion that is just posterior to the medial loop of the cavernous ICA. And this step consists in a widening of the anteromedial triangle of Dolen-Kakuba here. And then you have to step 4 that is directed to this part of lesion, especially giant pituitary adenoma or recurrent pituitary adenoma here, where the pattern of growth is just anterior to the medial, cavernous sinus medial loop of the ICA. And this step is directed through the so-called infratrochlear triangle that is, that is also known as a Parkinson triangle. This triangle is very, very important because it was the first triangle through which Professor Dwight Parkinson performed the first ligation of the, carotid cavernous fistula here at the level of the inferolateral trunk arising from the lateral part of the cavernous carotid here. The step number 5 is again, directed toward the 6th cranial nerve at the level of the infratrochlear triangle here and toward the medial loop of the ICA. And then you have the step 7 that is an intradural step. You have to open the dural step. You have 5 steps that are totally extradural. You work under the brain. You don't touch the brain. But at the level of the step 6, you have to open the dura here, and you can convert the interdural space with the common space that is a combined intra and interdural exposure. You make, wall space through which you can remove all this kind of tumor, and you can remove everything, by transcranial approach with step 6. And then this is just an overview of what you can see at the end of this surgery. You have different kind of intradural corridors. You have an interchiasmatic corridor here. You can work just lateral to the ICA, and you can work at the level of the, opticocarotid recess here, going down to the cellular and intracellular space. And this is, other corridors through which you can remove, this is step 7. Through step 7, that is the last one, you can remove the, the posterior clinoid here to enlarge and increase the space and the working space and the so-called angle of attack at the level of the retrocellular area. And you can finish to remove the tumor at the level of the interchiasmatic, space, as you see in this picture. And this is just an overview of what, is the versatility of this pretemporal transcavernous approach. This is a picture of one of the best articles that I read in my life, maybe. And this is, an article from one of my best friends from Taipei, that is Professor Senfok Su, that schematized and, summarized the main corridors to the transcavernous approach to the paracellular and retrocellular area. And I hope that this just overview and this refresh could be useful for young neurosurgeons that start to deal with this kind of complex surgery, this complex pathology. And sorry for, if I took too much time. Thank you so much. Can you hear me?
Yes, thank you, Professor Luzzi, for this very beautiful presentation and these spectacular images, anatomical images. Thank you very much.
I'm totally available if someone has some questions or...
Yes, are there some questions in the audience?
Sorry, Emad, can you send a link to Anil? Anil is saying his link is not working. Maybe please, can you send it to him now? Sabino, again, awesome talk. Really enjoy the way you take us through all those different steps. Amazing. I think it's good for young people to see all this.
Thank you. Thank you so much.
Okay, so Bonsang and Mona, you want to wrap up this session so that we can move on to the next session, please?
Yes. Yeah. Thanks to all the great lectures, and I think we can close the session for now for this session, and we move to the next session. Mona.
Yes, thank you all the speakers for these excellent conferences. Thank you very much.
And Imad,
And-
sorry, can you please help Professor Michael Feeling to read this video? He's having difficulties switching on his video.
Can I fill this gap for a few seconds just for a comment that we have almost more than 200 people online. This is beautiful because it means that, you know, all of these guys are very interested in this event, and I'm not seeing it on YouTube, but they are telling me that on YouTube we are even more people. So this is a great success, and it means that lots of people are with us, and this is the main commitment of World Federation Neurosurgical Society that is bridging the gaps between countries. And so congratulations, guys, once again, and thank you for Muna that is moderating, you know, this directing. Despite all these unexpected, you know, delays and everything. Congratulations from the bottom of my heart.
It was a honor. It was a big honor for me, and I enjoyed very much listening for all.
Okay, I think
So,
sorry, I was just going to move forward. Thank you, Mona, and thank you, Bonsang. I think it was
thank you,
excellent.
Professor
Thank you,
Salman
all the
Sharif.
speakers.
Thank you for your.
Yeah, wonderful. I would request Professor Zalili, if you're still there, maybe you could moderate. Mike Steinmetz has got stuck with some appointment, and Amal, we can't get through, so both are not here. So I'd appreciate if Greg Trost, if you are there as well, you can maybe moderate as well. Let's see.
So he's here, but he's not.
Salman, do you need something from me?
His mic is not. Yeah.
Roger, maybe what you could do is you could moderate this next session for us. Yes, that would be great. It's a research session.
Sure. I don't have the agenda though. Can we?
Okay.
Can somebody open that?
Imad, can you please send the agenda, or just send the agenda to Roger, please?
Sure.
And is Greg, are you around?
I am around.
Okay, brilliant. Greg, could you please moderate this session as well? And you, Imad, can you maybe share the agenda on the screen so that everybody can see that, and then we can move on. So it's so good to see Michael and Greg together. You know, I like the beard, and I like the, I think amazing.
Let me just. So this session is which one?
The research session,
Okay.
where Mike Steinmetz and Amal were supposed to moderate.
Oh, okay. So are we gonna have a 10-minute lecture first, or is this a?
Yeah, all these
are all
lectures are
lectures.
10 minutes.
These are all lectures, correct?
Yeah.
Let me just. So the first speaker is going to be Farida Amar Ali from Pakistan, talking about smart science using AI to build better research protocols. How's that?
Yep.
Okay.
Imad, are you sharing this?
I'm not sure I can hear the audio very well. This is a video.
Yeah. Imad, can you sort out the audio?
Hello and Assalamu alaikum everyone. Thank you for the introduction and inviting me over for this talk. Well, AI is everywhere, and today I'm going to share how AI can make medical writing smarter, faster, easier, well, maybe not wiser. So here is a disclaimer, just a quick note that not getting into the ethics associated with AI use today, because the presentation is time bound and I will have only 10 minutes. So it will be all about how to use AI smartly in protocol writing, especially for the postgraduate trainees who already have a lot of things on their plate. And I completely realize this. So ChatGPT and any other language generation tools are using deep learning to generate text that feels human. And the question is whether this technology can actually help us develop a research question, a research protocol, and plan for research. And if yes, then what is the smartest way to do that? And that too for free. So that's the best part, actually. So what are the merits? Anybody can do it, of course. You can get readable drafts in seconds with a perfect format, style, references, all lined up. It saves hours of actually staring into the space, thinking of what to do and how to do it, especially when you don't have a clue of research and medical writing. So it all begins with the prompt, and the prompt is the first instruction you would give to the AI. What outcome do you need, right? And it should be precise, and because it determines the outcome, it should be as smart as possible. So when we give a lazy prompt like give me a neurosurgery research question to ChatGPT, we should not expect much. As you can see here, that ChatGPT just gives you one question, which may not be feasible for your setting and may not be doable as well. So what's the trick here? You give a precise, smart prompt to AI. You need to first set a role. For example, you tell the AI that it's a neurosurgery research assistant or a neurosurgery postgraduate trainee. Give it a goal, like design feasible and novel research question. Third, you need to add context. For example, our hospital in Pakistan, we see around 10 to 15 patients with tumor. We operate 20 to 30 spinal surgeries. We do 20 to 30 minor cases each month. And then, you can also add in some do's and don'ts. For example, you can tell ChatGPT to give you real references in a specific style, for example, Vancouver style. You can also ask AI not to give you any fake references. And you can also tell him that, the references need to be from PubMed only, for example. So with these steps, you see, the output shifts from vague ideas to actually relevant questions on which we can build into a protocol. So here's the difference, you see. Now it's giving you 10 questions. A bad prompt, it will just give you generic stuff you could Google even. A better prompt will give you more ideas, which may not be actionable. But the best prompt, a precise, smart prompt, will give you questions for studies which are publishable, contextual, feasible, and then you can, choose from so many different questions. So as a public health professional, I was more interested in question number 9, which is what is the rate and pattern of unplanned readmissions within 30 days after neurosurgical procedures in a tertiary care hospital in Pakistan. So I wanted ChatGPT to write an introduction for the same question, and that's the prompt I gave it to ChatGPT. It was just followed by the questions which it developed for me. And it gave me an introduction here. And these are the references. So I remember, while making similar presentations a year back, I was talking about how AI would create fake references, what we call as hallucinations. So while reviewing certain papers, I just had some idea that it was generated from AI, and then I went back to those references which were cited, and there was no references in PubMed or Google Scholar or anywhere in any database. And that's when, we started realizing that ChatGPT is giving you fake references. But I think that, the newer versions of ChatGPT are smarter. Seems like they're already on antipsychotics, not hallucinating anymore. So now, you see all these references marked. If you click it, it's going to take you to the original site and to the original source of the article. And guess what? It's all in, formatted in Vancouver style or however you might want it. So the next thing I did was that I clicked on this CPSP, College of Physicians and Surgeons of Pakistan website, and I picked this PDF document, and this shows the requirements for a research protocol submission for postgraduate trainees. And I'm sure all the other trainees around the world will have guidelines for submission, either for ethical review boards in their own institutions or institutional review boards, whatever you call it. So I've just attached a guideline over here, and I did the same with ChatGPT. I asked ChatGPT to provide the draft for all these questions, and there you go. It gave me all the introduction along with the methodology, the data analysis, everything, just on the format of CPSP PDF document, which I attached here. So that's, how we go from just a brainstorming partner to a near draft protocol in just a couple of steps. But of course, there are certain challenges. AI is not perfect. It can mix up facts. It can also cite random things. It can give you contradictory answers with full confidence. And yes, sometimes it also sounds like every paper was written by the same boring robot with similar vocabulary. You might have noticed that, it uses the same words again and again, like navigating, delve, landscape, embark on the journey, something like that. So of course, AI does not have those complex cognitive networks humans would have. And then there are bigger worries like plagiarism, bias, dependence. And if we only rely on AI, we might miss important literature. We may weaken our study rationale. We make huge blunders, like, you can see here, these are manuscripts submitted to Alzheimer's, and you can see how the tool is great with a bad master. So even if you're copy pasting, you need that intelligence, right? This is another example of a huge blunder, and the editors and the peer reviewers would pick that. And it just spoils your credibility when you are submitting to a scientific journal. So yes, even though I'm not talking about ethical concerns, but it is something which needs to be discussed and pondered on. So global bodies like WAME and ICMJE, it says that chatbots are not authors, and they can't, of course, take the responsibility, sign a conflict of interest form, or for that matter, even stand in front of your supervisor, editors, or peer reviewers to defend you or themselves. So if you use AI, say it. Mention the version, how you used it. Always double check the references and sources. So this is very interesting. I found this meme on social media, and I thought I should check this with ChatGPT. So I typed the same question in ChatGPT, and here's the response I got. So you see, AI doesn't lie or cheat. Humans do. I'm sure AI will not replace us completely, but people who use AI smartly, they may outpace those who don't. These are my references, and if you want, you can use ChatGPT version 4, or this is another chatbot, which is Quillbot. This is a very good research chatbot, and you can use it to generate questions and even write your manuscript as well, in an ethical way, of course. So this is the take-home message. Use AI as a tool in medical writing, not as a crutch. And if you need to reach me, you can reach me on this email ID. I may not be as quick as an AI to respond to, but I'm certainly going to try my best. So thank you very much and good luck.
Your comments.
I have a comment. This almost seems like cheating to me. The journals now are actually using AI to help with plagiarism, which I think is a great tool. But I get worried that somewhere down the road that we'll use this technology, and there'll be a lot of sort of repeated statements and writing and so forth, and it's going to get flagged as plagiarism. I would encourage people to continue to be original and use their own original thought.
Yeah, I would, as a journal editor, just point out that there are tools that the journals use to highlight when AI has been used to generate a paper. And there's certain types of phrasing, etc. So I think, though, that potentially, legitimate use of AI, say, in the writing of a paper might be, particularly if someone does not have English as a first language, to use AI tools to edit the paper, to correct for grammar and spelling. That's a legitimate tool, and that can be mentioned in the methods. Like, that's a legitimate tool, so it can be used as a replacement, let's say, for a medical editor. So, but I would really strongly advise people not to use AI tools to actually write the paper itself. There's a very high risk there that one could run into plagiarism issues and inaccuracy issues.
Okay, shall we move on, please?
As the segue, Michael was just speaking. So Michael Failings is the next speaker who's going to talk about result in manuscript writing.
Thank you. And I'm traveling, so I prepared a video. I'm here, so let's see if the video works, if we can play that. If there's a technical challenge, I'll share my screen. Hello, I'm Michael Failings from the University of Toronto, and it's a pleasure to take part in this WFNS symposium on scientific writing. And I'm going to be discussing the results in manuscript writing, and really kind of focusing on the pearls and pitfalls of scientific writing. I have no specific commercial disclosures. I have a regenerative medicine biotechnology, a startup that I run at arm's length, and I am on the editorial board of several basic science and clinical journals, and am editor-in-chief of Spinal Cord, which is one of the Nature publications. So I'd like to acknowledge a number of people, including Professor Salman Sharif, who's the coordinator of the WFNS committee activities. And I wanted to thank and acknowledge my two co-moderators, Drs. Hamden and Steinmetz. So in terms of the objectives of this lecture, I'm going to discuss the approach to writing a paper, including some brief comments on various types of papers that you may wish to consider putting together. I'll present the Equator Network guidelines on how to present a report, and then I give a few pearls on how to choose a journal, and then how to handle rejections or requests or revisions. Then I'll discuss some common pitfalls and end with some pearls. So in terms of laying out the paper, so the paper typically has an abstract, introduction, methods, results, and discussion. In an abstract, often the use of a structured abstract with distinct subheadings can be an effective approach. It depends on the journal guidelines, but it is critical to summarize the key points: the rationale, background, the question, hypothesis, the methods, key results, and main results and conclusions. Now, the introduction is distinct from the discussion, and sometimes I see people mixing the two of these up. In the introduction, it's important to cite just enough literature to frame the question, but it's critical that you state the research question or hypothesis clearly. Then in the methods, it's important to provide all the key details in the subjects, outcome measures, controls, the length and completeness of follow-up. In the results, here it's important to make effective use of tables and figures, as this can summarize information effectively. In the discussion, this is often one of the hardest parts of the paper to write. The opening paragraph, I would recommend that you summarize the key results, and then subsequent to this, you should discuss 4 or 5 key points, and each point will be a separate a paragraph. And then depending on the formatting of the journal, sometimes one can use subject matter headings. It's important to discuss the literature that agrees with your findings, but especially any literature that may not entirely agree with your findings, and it's important to discuss this. Now, for a technical report, a case report, this really should be unique and provide novel insights on treatment strategy. It's very helpful if this is very well illustrated, and you should really try to avoid publishing cases that only marginally add to the literature. Now, case series is the most common type of surgical paper that we see, and the keys to success are if this can be prospective, and I recognize that this may not always be possible. You should try for a minimum of 1 year follow-up. In many of the journals, particularly if you look, require it to, if possible, use validated outcome measures. Try to have a high rate of follow-up, at least 80%. Clearly document the clinical and radiological outcomes. Have a clear documentation of complications, and if possible, include a control group so that you're actually comparing outcomes. Now, for basic science or papers or experimental reports, the keys to success, having a clear testable hypothesis that is of a clinical or basic science significance. And there's a magic 5-figure rule. You should have enough data that you have 5 key figures to present. The quantitation of results is extremely important, and the quality of the images is a critical point. Now, I want to share with you an important development related to reporting guidelines to facilitate the publication of papers. And this is summarized through an online service called the Equator Network. And this is the website information for this. And the Equator Network provides you with a very easy to access set of guidelines on how to report papers. So, for example, for randomized trial, the famous CONSORT guidelines; for observational studies, the STROBE guidelines; for systematic reviews, the PRISMA guidelines, and so on and so forth. Even case reports have particular guidelines, and these are called the CARE guidelines. And this is summarized here. So this is actually a checklist of information that you should include when writing a case report, and this is summarized here. So it gives specific information on what you should include in the abstract, critical information related to the introduction, patient information, clinical findings, and so on. So this is very helpful if you're considering writing a case report. Now, another set of guidelines, these are the CONSORT guidelines, and these are the classic guidelines to use when reporting a randomized trial or perhaps a prospective comparative effectiveness study. And this has kind of the classic sections with the title and abstract, introduction, methods, and so on, but it goes into very specific details on what one should be presenting. And then in terms of the results, specific data on the participant flow, the recruitment, baseline data, the analysis, the outcomes, adverse events, and so on, and then the discussion. And what's important here is really kind of the interpretation of these data. And this is a key figure. This is typically figure 1 in the presentation of large prospective clinical studies, and this is the so-called CONSORT diagram, where you're looking at the total number of patients that were assessed and how many were actually enrolled or randomized into the study, and what were the arms, and then what was the ultimate follow-up, and what was the dropout. Now, how do you choose the most appropriate journal? So one of of the techniques that you can use is examine your bibliography. Where were the papers published? This is often a very good place to start in terms of journal selection. And then look at the personality of the journal. What types of papers are listed in the instructions to the authors? What types of papers tend to get published in these types of journals? And then one can, of course, look at the impact factor. One can look at the citation index. But I think it's more important that your paper actually fit the personality of that journal. Now, very commonly, when you're submitting papers, you're asked to provide revisions, and occasionally you need to handle rejection. So rejections are tough. What I do, and I receive these as well, put the letter away for a day or two and come back to it. What can you learn from the reviewer's comments? And try to revise the paper to take advantage of the criticisms received, because more often than not, at least one of the reviewers who had previously seen your paper will be reviewing that paper again when you've resubmitted this. Request for revision. So here, this is very important to differentiate the points that require clarification or discussion versus the points that require additional data analysis or new experiments. The response letter is absolutely key. You should clearly raise each point and summarize the way this has been addressed. And if you disagree with the reviewer, you can rebut the points raised, but it's important that you do that with literature support, and you should be diplomatic in your wording. Common pitfalls: failure to comply with the author's instructions. So look at these very carefully. Typographic or grammatical errors can be a fatal error. So it's very important that you go over this carefully. And if English is not your first language, consider using a medical editor familiar with English. The abstract, you want this to be informative and avoid overstating the results. The introduction, it's commonly too long and then often does not state the key question and why this is important. In the methods, it's very important that you follow the guidelines, and the Equator network is extremely helpful here. So subject selection, length and nature of follow-up, outcomes assessments. And then the results. Try to make effective use of tables and figures, and avoid having tables and figures that duplicate the same data. And a common error is when the discussion is too long and it's unfocused. So think about 4 or 5 points that you're going to discuss, with the opening paragraph representing a summary of the key findings, and the concluding paragraph summarizing everything and then pointing out the next steps. So key pearls. Again, follow the guidelines outlined in the Equator network. Very helpful. I always write the methods in the results sections first. These are the most straightforward to put out. The introduction. I include only enough literature to establish why the question being asked is an important one. Frame the question or hypothesis to make it interesting and relevant.
I think
sounds like there might be
some audio issues there, but I think we can probably stop the presentation here.
Colleague, read the paper and to critique this.
So Michael, there is a question in the chat that says, how important is language polish and professional editing in international journal acceptance? Is it mandatory?
Well, I would say that a clearly written paper is important, and I reckon it's difficult even for people who have English as a first language to write clearly. It's an art, for sure. I think that if English is not a first language, it can be helpful to have an English-speaking colleague or even a medical editor review this. And as I've indicated, one can use certain AI tools in a medical editing sense to correct, to correct grammar, syntax, and flow. it's important to avoid grammatical errors and spelling errors. So it is very important for sure.
I mean, people are judged against the same standard that an English-speaking writer is doing.
Yes, that's correct.
Can I ask a question?
Yes.
Hey, Michael, how are you? Good to see you.
Good to see you, Roger.
Good. I had a question related to the previous presentation, but also related to your presentation, of course. Let's say, I'm not that familiar with AI, but I noticed like if you, let's say you have to write a paper about complications of a particular operation, right? Or book chapter. And you
Yes.
put that into AI and you say, list me the most common complications of this procedure and give me some details about that. And it spits out like this whole list of complications. Is that at what point does this become then, and you use that then to write your book chapter, but you rephrase it. But at what point does it become illegitimate? Or at what point does it become, plagiarism or questionable? And at what point is it actually a helpful tool? Because it is somewhat helpful, right? I mean, it gives you some, maybe you would have forgotten some of the complications otherwise. So,
Yeah, I mean, I think
it's a gray zone, I guess.
Yeah, Roger, I think the way you're describing the use of AI is as a search engine and as a tool, and in a sense, it's very similar to Google Analytics, right? Which also employs AI, and so I think if you're using this as a search engine to assist you with a literature review, but then you're taking that information and you're phrasing that with your own language and putting it together, I think that's entirely valid. I have no problem with that at all. You're using that as a tool. So to me, that's similar to doing a PubMed search or doing Google Analytics or, and so on. I think what's important to recognize is that most AI tools, including ChatGPT, are dependent on the quality of the informational literature. So if you are searching a topic and you have a very precise question and there's a very extensive validated literature, you're going to get a quite a sensible response. But if you don't word the question correctly, or if the literature maybe is a lot of gray literature, so for example, a lot of people's websites where they're making various outlandish claims on their websites, that can also appear in a ChatGPT search. And so one needs to be very careful around this. And so one always needs to look at this. And I think the previous speaker emphasized the importance of, a human being critically analyzing this. Okay. And so again, I would really caution against just putting in, write me a book chapter on topic X and out something spits. I think that is very concerning from an ethical perspective, firstly, but also it can often spit out information that's incorrect. But what you described, the use of as a search engine, as a tool, is entirely valid. And I think that's actually a very correct way to use that as a tool. And similarly, the use of AI medical editing tools to polish the language, to check for syntax and grammar, that there's absolutely no problem with that. That's absolutely fine.
Thank you. Sounds reasonable.
I think let's move forward. Yep.
Okay, great seeing all of you. Thank you again, and Solomon, thank you for putting all of this together.
Thank you very much.
So the next speaker is Anil Nanda, talking about meta-analysis and systematic review, if he's around.
I'm here, Greg. I never disappoint you.
Hey, Neil.
Can I share my screen?
I hope so.
Yeah. Let me see. It doesn't say, where would it say share?
So on the bottom.
Yeah, I got it. Share. Okay. Share. Let me see 1 second. Thank you again, Salman, for putting all this up. We really appreciate it. And Just to tell all the participants, you've got a real mega star lineup here. Firstly, Salman, thank you for your hospitality. And, events like this create a lot of intellectual cross-pollination, and we don't get enough of that in science. In a time when there's so much strife all around the world, this brings us all together in a wonderful way. And just for the audience to know, let none of these people fool you. Greg Torst may look like Santa Claus. He's an avid bicyclist. He's probably one of the best spine surgeons in the world. So don't let his Santa Claus look fool you. And same with Roger Hartle. He's probably the master of minimally invasive spine surgery. And so he's a great guy. And the thing about Mike Feelings, I'll tell you that, the H index, I think he has the highest H index of any neurosurgeon. I think it's like 115. And I wanted to tease him. I was in India last 2 months ago, and one of the diabetologists there had an H index of like 145, which is the highest for a scientist in India. So like, oh my God. So I'm going to run through this for systematic reviews. My fellow Daniela helped me put some of this together. So it's great being here again, and I love this format. And I'm sure all of us are going to be in Dubai, which should be a fun time. But just to briefly, let me just get this. Yeah. So this is just to give you an overview of the data. I'm trying to get this straightened. Mike's still on, Mr. H Index Master. So you can see here, this is how we sort of look at it. There's background information, expert opinion, and, in the litigious area that we live in the United States, that becomes very, very moot. There's unfiltered information, RCT, cohort studies, and then of course filtered information. So the real apex is systematic review. So it's something we kind of use a lot of and is very helpful. And there's a certain thing called wisdom. I mean, a lot of people say that we're not up to date with medical knowledge as experts, and that sometimes we are mired in sort of antiquity and we don't adjust. But this I thought was a great curve about clinical judgment, tying up-to-date knowledge. And you can see the lines don't meet. So we're never up to date. The best expert may not know the latest study. So I think it's just something to remember and be cognizant of. And when you're doing your research, I think, and we've had great talks on AI, how to write a paper. I think the most important ingredient in publication is intellectual curiosity. There's papers on the ways Shakespeare characters died in their plays. Like it was an analysis. How many people died with stabbing? How many people died with sword fights? And it's a fascinating study. I found it interesting. And something as pedestrian as a drainage after subdural hematomas, which is like a pedestrian thing. We don't think much of it. But that got published in Lancet. Some resident in England said, I'm going to send a survey out. And then they did a randomized trial. And they showed you put a drain in for 24 hours, your outcome is better. So I always urge the residents and the younger people to think out of the box, think for interesting things, think tangentially. There's studies on pterional craniotomies, which is like the bread and butter of every craniotomy, but very few people look at olfaction. And so there was a great paper on how olfaction is affected with a pterional craniotomy. So if you look at the extraordinary in the ordinary, you'll come up with a good paper. So that's something I think AI cannot give you, is that spark of innovation. Think like Steve Jobs. You don't have to take LSD to get there, but you can try, okay? So these are just some of the plans, like plan, search, screen, abstract, clean report. And I think the planning should be meticulous. And one of the biggest things I see with neurosurgical residents or younger neurosurgeons is they'll have a great paper. They'll go present it, and then it goes into the land of cobwebs, okay? It's never executed. So that execution, planning is good, but execution is much more important. So I think there's been several surveys that you go to WFNS, CNS, or EANS or WFN, you present a paper there. The conversion rate of a presentation to paper is less than 30%, which means 70% of that effort is kind of wasted. So you don't want to be in that 70%. So like Mike alluded to, there's guidelines, and I think with meta-analysis and these data surveys, you want to look at databases. I think the Prisma checklist is the one we use. It's very good. It's a good screening method. How do you get there? What do you divide? What do you look at? So it's something that's the way you do. And I think this PICO question is very good. What is the population? What is the targets group for the study? Are you looking at people with tuberculosis? Are you looking at somebody with metastatic cancer? What is the intervention? And what is the comparison? What's the alternative group? I mean, there was, Atul Gawande wrote about a palliative care for terminal lung cancer, and the outcome was better if you did nothing. So not that that promotes nihilism, but it makes you think different, and it diminishes the hubris you might have that by saying, "Well, I treated all this, but really, did it make a difference or not?" So that comparison point is very important. And outcome, what is the benefits from it? Where do you get with that? So this PICO is very good. It's a good change. So this is an example of PICO. Does vitamin C prevent and treat the common cold when compared to placebo? Linus Pauling, the guy who got 2 Nobel Prizes, that was his big thing, and it didn't work. So we still take vitamin C, but it's an important question. You think of intervention, outcome, comparison, and population. Yeah. So the registration for this is you can register on Prospero. This is a great way. We recommend it. We use it. It's a good thing to try. And then again, plan Prisma guidelines, Prospero, then establish product, and sort of look at what your project is going to do. I think the thing that I really like to stress is an exhaustive, reproducible search. And this takes hard work. This is not something ChatGPT can do for you. And when you present or you write a paper, this is aimed for the younger people in the audience. The good thing is you become an expert in that. If you're looking at Rosi Dorfman, okay, I took out a meningioma 4 months ago. We thought it was a meningioma, looked like a meningioma. Turned out to be Rosi Dorfman. I have a fellow, Daniela, who's brilliant. And I said, listen, let's look at this. And she got Rosi Dorfman in the spine, Rosi Dorfman intracranially. It's a rare disease, but Daniela is now an expert on Rosi Dorfman. So you will get enriched by your search, which something ChatGPT will not do. And there's studies to show that people that write their own essays versus having ChatGPT, the retention rate, if you write yourself, is 10%. If you get ChatGPT to do it, it's less. It's the other way around. If you write it yourself, 86% you retain it. If ChatGPT does it for you, retention rate is less than 15%. So you don't get smarter doing that. Again, the terms across different databases. So if you look at author names in PubMed, Embase, and Web of Science Translation, then you look for date of publication, you look for the title, you look at the subject. So there's certain tricks to this that you just need to be acquainted with. So if you have that, it makes your search a little bit easier. Again, document, search string, use of filters, very important. And I think you have to have an exhaustive search because part of a meta-analysis and review is it's a filtration system. So you're going to look at this, you're at a water hydrant, you take all this off. What you want is a clear, transparent glass of water. And how you get there is all the hard work. So again, you want to have at least 2 reviewers. And I think one of the things we're seeing in submissions is, besides plagiarism, there is scientific fraud, okay? Some of the most highly illustrative sort of institutions in the world, they look at the DNA pictures or they look at some of the, electrophoresis, it's fudged. So again, you want to be careful on that. And I think ethics is a whole different topic. Again, this was a simple topic. We were looking at pediatric patients, look at inclusion, exclusion criteria, be very detailed and succinct about it, and then screen the patients. Okay, you look at all this document screening, full screening, and then you put all that in a sheet. This is just a paper that we sort of looked at effectiveness of group art therapy and quality of life in pediatric patients with cancer. This was an RCT, how we went about it. We did abstract screening. This is Daniela, my fellow, did this. And again, you prepare the abstract, retrieve all the articles. So I think it's very, very, very detailed. Again, critical appraisal, the risk of bias. You have to assess your selection, attrition, biases. And so there's several methods you can do that with. Again, study type, there's primary twos. I think Mike talked about it, Rob 2, Robbins. the JVI, Quadus, all those are there. These are easy to follow. And then the grade, you kind of rate each critical outcome and you downgrade it, put the observational stuff in. And I'm going to try and finish because I only have 10 minutes. So here again, PICO question, you look at certainty of grade. This is a little complex slide, but very useful. And then I think I'll talk briefly in the time remaining about meta-analysis. So you want to choose the right effect size, calculate it consistently across studies, pool them using a good statistical model, and then assess the heterogeneity. Find out if it's a binary, you look at risk ratio, odds ratio, risk difference. Statistics and science has become a whole language of its own. As good as you think you might be, you're like, oh my God, there's more to be learned. So I always tell our residents and fellows, make sure you're good at this and that you can be knowledgeable. So we want to extract data for effect size. There's a fixed effect model and the random effect model. And there's these mathematical ways of doing it. And then you assess heterogeneity. So again, the 95% confidence interval of the result on the graphic side, result of the study, I think is very important to show. In the last few minutes that I have, I'm going to talk a little bit about, we started a new journal, the WFNS journal, and we really wanted a journal that was not Eurocentric or Americocentric. We wanted a global view on this. So this is good old Tina Turner that only Greg and I probably remember about the song, We Don't Need Another Hero. But for the younger people, I'll tell you, it's a good song. So this is the voice of 40,000 neurosurgeons worldwide. We've now indexed in Google, and hopefully by next year we'll be on PubMed. We're doing a bunch of special issues. We have a really nice international board. We're doing special issues on trauma, and so I invite the younger people to contribute to it. I know there's been a lot of turmoil in the world and a lot of turmoil in the WFNS, but this is Carl Sagan's beautiful picture of the planet Earth, and he says, on a mote of dust suspended in a beam. On it, everyone you love, everyone you know, everyone you've ever heard of, every human being who ever was, lived out their lives. That's what reminds us, that brings us all together. This is a picture of Earthrise that was taken from Jim Lovell. So it kind of reminds us, it's the old the African line of Ubuntu, I am, so we are. So on that note, I'll end this. Thank you again for the opportunity. Congratulations, Salman, for putting on a great show. And anybody has any questions about the journal or any of this, please feel free to contact me. Thank you so much.
Thanks, Anil. Hey, there's one question in the chat. It says, how do you decide if a question is best answered by a systematic review or a meta-analysis?
I think that depends on the question, really. You know what I mean? If it's too broad-based, you may want to select what's better. I like reviews because they look at everything, and maybe the moderators want to chip in. I think, Mike, any comment on that?
Mike is traveling from Houston, which is
Oh
why
my
I'm sitting
God,
here
that's a long way away.
Yeah.
I might reframe the question a little bit. I think sometimes, when you do a systematic review versus a scoping review. So just to clarify, a meta-analysis is a systematic review. It's a quantitative analysis of the data that arise from a systematic review. It involves the generation of forest plots. Sometimes the data don't allow quantification and one needs to do a qualitative synthesis. An alternative form of a review is a scoping review, where you do a very broad literature search, but your questions are much broader. And so I would encourage the questioner to perhaps look at the definitions of systematic review, scoping review, and then the meta-analysis is what I've said that is encompassed within the systematic review.
Neil, I have a question, maybe half comment. What's the one thing you find that really weakens people when they submit a meta-analysis? And my take was always that they include inferior quality papers that may support their view, but are not quality.
Yeah, I think there's a bias, and sometimes weaker papers are admitted to slant it a little bit. You know what I mean?
Yeah.
As much as we like it, we all have our inherent biases, and it should never project on. But I agree with you that weaker papers, questionable papers will burrow their way in, and And, sometimes we see like great papers, some papers have been completely missed out. You know what I mean? And when you're the author, like somebody wrote a big article on petroclival meningiomas. I'm like, wait a minute, where's my paper on this? You know what I mean? So you're like, how did this happen? And it's not a personal thing. It's probably an oversight or something. But I think, it's important to sort of view it with that lens. I mean, I think Franco Cervede, I was in Zurich at a meeting and he talked about MMA. And they did a nice sort of review of 3 papers and said it's not mandatory, which is, it's interesting. It's like the decompressive craniectomy study. The Europeans said it really doesn't work. You're going to have more vegetative people. The Americans said it's great. We're making more people keep them alive, and our nursing homes are full. So, sometimes there's a subjective bias on interpretation of even a good paper. And we look at, maybe this suits our point of view better or not,
Right. I always enjoy listening to Neil talk. And thanks for the kind words. I'm none of those things. So
you're an amazing bicyclist. Don't let them fool you. He and his wife are like amazing athletes. I'll tell you that.
we're old now. We're not amazing anything.
You're not old, man. Come on.
All right. Time to move on.
Yep.
Okay, we have last speaker in this session is Murat Seker Eksi. I'm sorry if I massacred your name, from Turkey. And his talk is on publishing a paper.
Hi, everyone. Do you hear me?
Yes.
Okay.
You need to share your screen.
Yes. Can you see my screen?
Yes.
I thank to Dr. Professor Sharif and Zili for their kind invitation to this great meeting, and also it will be very hard for me to conclude this session following Professor Felix and Professor Nanda. So I will go on with how to publish a paper in a scientific journal. This is my disclosure. As neurosurgeons, we have little time to spare our life with our families and less with writing paper. But so why should we do this? We can share our knowledge, experience, and findings with others. We can contribute to the body of literature. We get funded, promoted, and recognized by our peers. How can we publish a paper? There is competition for slots in the journals. Cost of publication is high, and rejection rates vary from journal to journal. What are the good components of a science? It should be novel, mechanistic, and descriptive. This is Bloom's taxonomy. You may know it composed of, at the bottom, remember, understand, apply, analyze, evaluate, create. When we impose this to publishing, we see we should know, comprehend, applicate, analyze, synthesize, and evaluate. How can we choose the journals? There are different journals on the world. The top journals like Nature and Science, they are very high impact journals and hard to publish. Then field specific top journals are coming, and other field specific journals and national journals. What should we look for a journal to choose? Actually, however, it's not very important, the impact factor. It's, as Professor Felix stated, your paper should be fit the journal scope and to reach as much as readers you want. But impact factor could be a reliable factor to submit, to choose the journal. And also lead time or incubation time, as we can say, the average time taken for a paper from submission to publication could be important for the authors too. First of all, before writing your paper, you should decide, is there a hypothesis straightforward or yours? Has a significant advancement been made? Did the experiments test the hypothesis? Could it be possible to describe the study in 1 or 2 minutes? Could you give key messages in 1 or 2 sentences? Tables and figures should be clear and concise. References used in the manuscript could be key to choose the appropriate journal. Also suggest the appropriate reviewers. These are the type of publications. I will mostly focus on the original paper. It is composed of title, abstract, keywords, introduction, methods, results, discussion, acknowledgements, and references. You should, first of all, begin with having a question. You translate that question in a hypothesis, and you should have the innovation and motivation to plan this study. And before that, after planning, you should review the literature. You should be expert of that area. Experience is important in writing as in everything else, so is mentorship here. benefit from the experiences of those who focus on and studies in your field. Work with people who have published their studies.
My mother always insisted that
How can we plan manuscripts? First of all, you should pick up your authors, who will be the authors, and define the role of each author, what they will do. You plan the steps of the study, when to start, how to conduct, and how to re-evaluate the results, which analysis will be done, and also cost of the study. First of all, begin with the writing with materials and methods. It should be reproducible, cite appropriate references if published before. There can be subheadings of material methods such as study design, participants, radiological assessment, clinical assessment, inclusion and exclusion criteria, institutional review board approval, and statistical analysis. Before going on with results, you should finalize your tables and figures. It will make it very easy for you to write the results. This is the part that the readers are most curious about your study. Write attentively. Irrelevant findings are not considered as a result and information. Avoid fishing. Do not say, I find this. Not. Only aim on your aim and your hypothesis. Do not manipulate the data. In introduction, actually, it's the zoom-in part of your paper. You will attract readers into your paper, build case for why your study is important and necessary to read. Provide brief background about it, state your hypothesis, and give a paragraph about what the investigation proposed to do in the study. This is an example for an introduction. You give the big picture, background knowledge, then you state your area of interest in this paper, present the gap of knowledge, why it's important, and your solution. Then you can pass to discussion section. First, answer questions posed in introduction. Discuss the possible mechanisms, discuss weaknesses and discrepancies, explain what is new without exaggerating, list your results in the order of their significance. There is no impeccable study. Please show your limitations. Do not repeat discussion or speculate too much. In conclusion, it should be very concise and give the summary, perspective, implications, and future suggestions of the work. The references should be relevant, be selected based on credibility, read the references before referring, do not misquote, and use correct style and format of the journal. And this is the very important part of your paper. Most of the authors try to write their abstracts first, but it's not the correct way. You should do it after finalizing your paper. It's critical part of paper. State main objectives, summarize most important results, state major conclusions and significance, avoid acronyms, write and rewrite until it is concise, provide the right keywords for indexing. When, as an editor, when we receive the submissions, we look the titles and the abstract as what it adds to the current body of literature. So it should be very accurate and should attract the reader's attention. Also, I sometimes notice that the keywords are not structured in a good manner, because if you use mesh terms especially, your research can be easily accessed by your peers who want to read your paper by using the mesh terms. Title will determine whether your paper gets read. Avoid long titles and avoid abbreviations. Acknowledge is the part when you cite your grants. People who read the paper or contributed to the discussion, not contribute as a coauthor, but give you idea. Technical and secretarial assistance can be stated in this part. Writing should start with method section, then go on with the results, attract readers in the introduction, make it zoom in, and in discussion section, you do the zoom out. And neither reviewer nor editors be native speakers. Knowing English well is not enough to write a scientific paper. However, the manuscript is not written simply and fluently. If it's not written in simply and fluently, the take-home message could not be understood by their peers. Before submission, careful review and revise your paper. All authors should participate. Only one is the corresponding author. Review order of the data presentation is important. Polish the writing style. Double check references. Look for typos and spelling errors. Double check spelling. Some journals need British English and some American English. How can we write a good paper? Read well-written articles, try to get good writers to review, learn from editing changes, listen to your mentors, learn from them, learn editing and correcting symbols, learn proofreading and correcting, good copy editing and formatting according to the journal requirements, and avoid plagiarism. And the most important one, do peer reviews of the other papers. You learn much more from them. During submission, please read the instructions carefully. Most of the papers, not most, but some of the papers are rejected if they are not according to journal's instruction to the editor's fully form. Fill out all necessary forms, write a cover letter, confirm receipt, follow-up communication, acknowledgeable. This part, respond to reviewers, is much important as writing a good paper. Carefully prepare yourself. Each comment should be addressed. Each change should be stated clearly. Be enthusiastic. Reviewer may be wrong, but thank the reviewers because they share their time for your paper without waiting anything else back. Do not respond to reviewers while you are upset. Wait for a while. Get help from your co-authors and your mentor. Address the corrections to the chief editor. We did our best, however, why are our papers rejected? Because your topic may be out of the journal scope, your sample size may not be inadequate, your results may be vague, or your manuscript is not known as much. Everything is good except your presentation through the paper may not be good. Peer review comments of the reviewers who are interested and expertise in the field. It aims to validate all the findings and to help findings be presented in a better way. In a chess game, who played the game best? The players or the watchers? Of course, the watchers. In here, it corresponds to the peer reviewers. Reviewers should let us evaluate the raw pre-published manuscript, improve the manuscript, help the authors write their findings in a more scientific and understandable way, contribute to the body of literature. Think of, if I were the author, how I would edit and write these findings. So you can also, my suggestion is for the young neurosurgeons, you can learn writing by doing peer reviews also. One last thing, let the manuscript wait for a while before submission, then reread and ask your partner to read it. Zoom out the manuscript with, is it novel, is it fluent, is it scientific? Thanks.
Great. Thanks for the nice talk. A lot of great advice for people. I don't see any questions in the chat.
Mike,
Rod, I enjoyed your talk very much, and I thought that you provided some additional perspectives that sort of complemented my talk. So I think that was really good. One point that I totally agree with, a couple of points you raised. One was when you get a rejection letter or a request for revision, put it aside for a day or two and then just reflect on it because it can be challenging. So I agree with that. The second thing I would also agree with is I would recommend that when you're putting a paper together to actually write the abstract last. There's sometimes a tendency to write the abstract first. It sometimes results in a distortion of how you're presenting this, and really the abstract is really a précis of the paper. So I really agree with that as well. And the abstract is the first thing that the reviewers will read. So a very carefully constructed abstract that also presents the results fairly, but doesn't overstate the results is really important. So I really agree with your point on that, Murad, in terms of the writing of the paper.
Thank you, Professor. And if I have a time, can I add something else? While you prepare to submit your paper, yes, you are exhausted while you are writing, and you want to finalize it as fast. But when you're doing submission, be careful about your cover letter, and also to be strict with the journal rules, because sometimes we receive submissions that are not really look in the path the journal wants that. And when we notice as an editor, when we don't see that picture, we think in our mind that the authors are careless. They do not really respect to be read by the editor or the reviewers. Because we are sharing our time for reading and evaluating that paper. So we want the same respect from the authors to be compliable with the paper's rules, the journal's rules, I mean.
There's one comment in the chat section that is, this is a nice review of how to successfully publish. 2 points that cause lots of papers to be rejected. 1, authors make too big of a claim from what data supports. Humble conclusions win. And 2, keep it brief. Long discussions cannot rescue small data. So
good point.
Good comments. Salman, I don't know if there's any time left, but
I
otherwise,
think we are running over, so I
close
think
this session and move on.
yeah, that would be
Thanks for
great.
letting me
Great.
pitch
Thanks,
in.
everyone. Great to
Thanks,
see you.
everyone. Brilliant session. Thank you.
Bye-bye.
Bye.
Thank you, everyone. Thank you, moderators. Thank you, presenters, for your amazing presentations. Now we'll be moving on to our next session, which is a pediatric session. And I would like to ask Dr. Hassan Syed and Dr. Shehbaz Shamim to please unmute themselves and take away the floor, please.
Thank you very much. Dr. Shamim, do you want to take the lead?
Yeah, hello everybody, and once again, thank you, Dr. Salman, for organizing all of this and making us a part of it. So I would invite our first speaker is Tony Connected. Yeah, there he is. Hi, Tony. So our first
Hi,
speaker.
can you hear me okay?
Yeah, is a very well-known pediatric neurosurgeon. He's currently the president of the South African Society of Neurosurgeons, Tony Figaji, and Dr. Anthony will be talking about integrating neuromonitoring in clinical care of pediatric traumatic brain injuries. Tony, over to you.
Great. Yeah, can I just share my screen there? Is that all right? Can you all see that?
Yep.
Yes, we can see it.
Great, thanks. So I'm going to speak about my thoughts, some based on evidence, some based on experience, and hopefully some wisdom on integrating neuromonitoring in TBI care with a particular focus on children, but I think most of these principles will be applicable to adults as well. So the first two high-level questions that anyone would ask about why would you be interested in integrating neuromonitoring in TBI care is why and how. And I'd start with why and maybe start with the first high-level question or answer to that question, that neurotrauma is important. It's important because it is by far the commonest condition across the world that we treat and manage that kills and maims the most people across the world. So much more than brain tumors and everything else that we manage. And unfortunately, we don't usually give it the attention that it deserves, especially if we say that our primary goal is to try to have the greatest impact on the conditions that we see or the patients that we see across the world. And there are different ways you can look at this. So if you look at the annual number of deaths in children across the world, and this is at least 100,000, I spend a lot of time thinking about and improving my skills to treat children with CNS tumors. But the truth is that the number of kids dying across the world, and this is just the tip of the iceberg because we're not even talking about disability, but the number of kids dying across the world far, far outstrip the number of children with CNS tumors that I spend most of my time with. And why specifically trying to integrate neuromonitoring beyond what we do? Well, simply because brain injury is complex. So this is in a single patient microdialysis reading. So the 5 metabolites that we typically follow with microdialysis by the bedside across 3 days, you can see how highly variable it is, changing over time. And so brain injury is complex, and it is, and I'll say a few controversial things, I hope, that'll get maybe some people riled up. But for me, knowing that it is utterly implausible that only treating raised intracranial pressure in a stepwise approach delivers the best outcomes. It doesn't really make any rational sense to me. We know that and often say that the brain is the most complex organ in the known universe. And I find it, again, implausible that the best we can do when it is injured is just to treat the pressure. And so very often, the first thing that neurosurgeons do is just think about not only treating the pressure, but surgically treating the pressure. And very often it comes down to, do I do a decompressive craniectomy or not? Which, of course, is an incredibly blunt way of approaching a complex condition. So what we know from the literature is that no monitoring at all reports the worst outcomes. ICP monitoring seems to add some value, but of course, knowing the physiology of the brain, we know that it is a blunt tool. And dedicated centers with multimodal approach report the best outcomes. We can't often point to exactly what aspect of that multimodal approach makes the biggest difference, but it seems to make a big difference to improving outcomes. And so ICP alone, everybody knows the randomized controlled trial of ICP monitoring, and there's been a lot of debate about that over the years. It's a very complex issue, but we know it's not at least what we know is it's not as simple as getting an ICP monitor, applying it to a bunch of patients, and then expecting a good outcome. And why? It should be fairly obvious, because there are many different reasons that intracranial pressure will go up. So hematoma, hydrocephalus, contusions, those are all very often surgical conditions, and we're quite comfortable with those, but then it rapidly becomes a little bit more complicated. So then there's brain edema and hyperemia and CO2 related increase in cerebral blood volume and impaired pressure autoregulation and subclinical seizures and even spreading depolarizations. So all these things happen in our patients. So it doesn't make sense that we can treat all of them as if intracranial pressure is exactly the same, and then approach it like we have done traditionally, historically over time, in a stepwise approach. So we start with one thing, if that doesn't work, we go to the next thing. If that doesn't work, we go to the next thing. It doesn't make physiological sense. And then on top of it, in pediatrics in particular, children are so much more difficult than adults because they are physically, physiologically different, and their patterns of injury are different, and they change as the child ages. So again, people tend to dig in their heels and they say, surely all I need is to just treat intracranial pressure. And we treat intracranial pressure to prevent herniation at the higher levels, but primarily to preserve perfusion in the brain. And when you plot intracranial pressure against any measure of perfusion, you find that you don't have a simple relationship. And people are often surprised by this, but they shouldn't be surprised if you know the physiology of the brain. And I can show you countless examples where perfusion and intracranial pressure, or any measure of perfusion and intracranial pressure, can go in two different directions, depending on what the underlying cause of that intracranial pressure is. And then on top of it, even if you could control intracranial pressure, it doesn't mean that you've done enough by the patient. And so this was from kind of many years ago. We looked at brain oxygenation, episodes of brain oxygenation below certain critical thresholds when the patient was ultimately well managed. So by the guidelines at the time, we thought we did everything we could, and still a third of those patients had brain oxygenation that was not only low, but was below critical threshold. So clearly, hopefully, I've elucidated exactly why we do neuromonitoring. So then the next question is, how do you do that? These are the tools that I use. Other people may use different tools and they may have different experience. And in this, unfortunately, there's not a huge amount of evidence. Presumably, it's the conglomeration of all these things that we do that seem to make a difference to outcome. So we always start with intracranial pressure and cerebral perfusion pressure. And I would suggest you also monitor end-tidal CO2 continuously. Then we use brain tissue oxygen in all our patients. We monitor pressure autoregulation. In some patients, and these are more selected patients, we use microdialysis. And we've also had some experience with transcranial Doppler, with near-infrared, with continuous EEG and biomarkers. And other people, for them, some of those may be frontline. And so this is the setup at the bedside. We have a bedside computer running a program called ICM Plus from Cambridge University that helps us integrate all the data, helps us to display it continuously. And this I find incredibly useful, because when you look at the continuous display of data with high frequency data, you can see relationships between the different variables that you don't really appreciate when you're just looking at a variable recorded every hour. We use brain tissue oxygen monitoring. Many of you know that. And we've got quite a lot of experience. Late on this year, we hopefully, if we can get a paper published, like the previous speaker just spoke about, we will publish our experience on probably about 450 cases and the things that we've learned over time. And then we've also been using microdialysis. For those of you who don't know, microdialysis is a tissue-based system that can monitor every hour the changes in 5 parameters, 5 metabolites: glucose, lactate, pyruvate, glycerol, and glutamate. So that's brain chemistry. So putting all that together in the very few minutes left, what have we learned over the years? We've learned that ICP is not predictable from imaging, so it doesn't matter how good you're looking. You think you are looking at a CT scan, it's not good enough to predict intracranial pressure. Intracranial pressure in children is different from adults. And this will be complex data, so I'll skip through it very quickly. This was high-frequency data in 364 children. Hopefully, we'll publish it also a little bit later this year. And the take-home message with this really complex grid of analysis here is that intracranial pressure associates with outcomes at lower thresholds than one would associate or one would expect in adults. And at the moment, our recommendations, our guidelines still recommend a very high threshold of 20 millimeters of mercury. Pressure autoregulation is clinically important. I'm really surprised by how few people understand the physiology of pressure autoregulation, because it's really important in how we manage blood pressure and what happens to intracranial pressure when blood pressure changes. So that's the typical graph that people know when they talk about pressure autoregulation, but few people appreciate the fact that pressure autoregulation can be impaired, and blood pressure manipulations that we do at the bedside all the time can have varying effects on intracranial pressure. So yeah, just two examples where you're pushing up the blood pressure, and it can either push up, at least, and can either drop intracranial pressure, or it can raise intracranial pressure. Same thing, two different scenarios in patients with impaired versus intact autoregulation. And autoregulatory capacity associates with outcomes, so it's important. I'll skip that in the interest of time because that's too complex. And the same thing is true for CO2. CO2 changes can be really tricky, and acute changes in CO2 can have variable effects on perfusion depending on the prevailing circumstances. So show you two examples of hyperventilation. One where the brain oxygenation and the cerebral blood flow, they often usually go together, goes down, and one where brain oxygenation and cerebral blood flow goes up. Again, the physiology is a little bit tricky and we don't have time to go into it, but just the take-home message is that it can vary. And then there's more to brain physiology than just intracranial pressure. There's mitochondrial dysfunction, there's subclinical seizures, and there are all sorts of different ways in which drugs get into the brain and vary between patients. So sorry, I don't have too much time to go into the nitty-gritty of it, but the message that I want to leave you with is that there's a lot more going on in the injured brain than we recognize, and we are mostly unprepared for it. Most neurosurgeons just think in terms of decompressive craniectomy, and we put our head in the sand for the rest of it. And so, summary, cannot deny the brain is complex. Secondary injuries are important. Simple approaches don't work. And better understanding of the physiology of the brain potentially not only improves outcome, but reduces the harmful procedures that we do. And just keep in mind, it's not the monitor that makes a difference, it's how we respond to it. Thank you very much.
Thank you, Dr. Fagaji. It was an excellent talk, and we really appreciate your wisdom and expertise. I guess for the interest in time, we'll just move on to the next speaker, Dr. Eric Srebnick from Columbus, Ohio, Nationwide. He's very well known for his work as a pediatric neurosurgeon and in traumatic brain injury. He'll be speaking on systemic immune suppression following traumatic brain injury, and is there an opportunity for therapy?
I am sharing my screen. I want to make sure that you guys can see it. Can you see my screen?
Yes.
Perfect. First of all, I just want to say that I am humbled to be sharing the stage with Tony Fagaji, Adrian Caceres, and Artur da Cunha. And thank you very much for this opportunity. And thank you for inviting ISPN to join. So I'm going to be talking about my research, and the first thing that I'm going to do is give just a quick case presentation. So this was a 15-year-old male who I met early in my practice as a pediatric neurosurgeon, and he was actually involved in a really severe injury where he was sledding and managed to get hit by a car while sledding. He had bilateral hemopneumothoraces. He had a right clavicle fracture. He had a right femur fracture. He had a non-operative spinal injury, and this is in addition to some pretty profound diffuse axonal injury. As with many places, I'm sure internationally, we have quite a bit of rural location in Ohio, and so he was nowhere near a hospital. He was hypotensive. He was intubated at the scene, flown by helicopter to our institution, and ended up getting 4 units of packed red blood cells. He ended up getting hypertonics, paralytics, sedation, full court medical press for his traumatic brain injury. And he spent 36 days in the PICU and had a 43-day hospital length of stay. In that time, he managed to get 2 separate ventilator-associated pneumonias, one of the most common ways that we get nosocomial infection and traumatic brain injury. And while when we're focusing on traumatic brain injury, we oftentimes focus on the brain, it is also quite apparent that nosocomial infection is a risk factor for patients with traumatic brain injuries. And this is if we compare it to other neurosurgical patients who have similar types of injuries during neurosurgery, and as compared to other trauma patients who do not have a traumatic brain injury. And I'll show a little bit of data on that later. What happens if you get a nosocomial infection? So it's not just a data point against the hospital. Following severe traumatic brain injury, the data for all comers is as high as 50% for nosocomial infection, and the subsequent mortality with infection is as high as 37%. So these are serious injuries that can lead to nosocomial infection. If we can reverse this risk of nosocomial infection, we potentially can improve outcome for this large number of patients. So what we see in pediatrics, this was early work that we did when I joined the hospital, was when we take children who have had brain injury plus an extracranial injury, that's in red, and we compare them to children who have had an isolated traumatic brain injury in blue, or polytrauma without traumatic brain injury, that's in green, and we compare nosocomial infections, we see that even if you assess for the number of lines and the number of hospital days, the patients with a combined injury, traumatic brain injury plus extracranial injury, actually have a higher risk of developing nosocomial infections. One way that we can look at immune function is by taking your blood, incubating it with an immunogen, in this case it'll be lipopolysaccharide, and then testing to see whether you release pro-inflammatory cytokines. In this case, it's tumor necrosis factor alpha, or TNF alpha. In my lab, we've developed a model whereby we induce a traumatic brain injury, and then we flip the rat over and drain about a quarter of their blood volume to recapitulate this TBI plus extracranial injury. And what we found is that if you look at these animals following injury, and I'm sorry, this is a busy slide, but if you compare sham injured animals with animals that have received just a hemorrhage or just a TBI, the animals that receive a hemorrhage plus a TBI have a significantly lower level of immune function. You can see that down here than their single injury counterparts. And so what my lab is dedicated to is reversing this. So one way that we do this is trying to improve the innate immune response. And one drug that we have used is GM-CSF. This is a naturally occurring pro-inflammatory cytokine and is used in clinical medicine. This study that we did, we injured the animals, ended up giving them pneumonia, essentially just gave them intranasal Streptococcus pneumoniae, and then looked at how they were able to clear the infection. GM-CSF is a hematopoietic cytokine. It induces granulocyte production and release, and especially monocytes. What we found was that GM-CSF reduces lung bacterial load. All of these animals received Streptococcus pneumoniae, but you can see that the sham-injured animals were able to clear that Streptococcus pneumoniae quite easily, whereas the animals that had that combined injury plus saline had a bacterial load, and this was significantly reduced when we treated these animals with GM-CSF. Now, one of the things that we look at is we can improve systemic immune function, but are we causing neuroinflammation? We looked at blood monocyte population using flow cytometry. And again, what we found was with that GM-CSF, we expanded the monocyte population. But again, we're critically worried about causing neuroinflammation as we expand the systemic immune function. And so one of the ways that we check for this is immunohistochemistry. And in sham-injured animals, there is a relatively stable baseline of astrocytes, that's GFAP, a relatively stable baseline of neurons that we can see using nu-N as our stain. And what we see is that in both the saline and the GM-CSF treated animals, we have similar levels of astrocytes and a similar decrease in neuronal population, suggesting that we are not increasing neuroinflammation with giving this drug systemically. Looking at neurocognitive function, we do this with a Barnes maze where animals are put in the middle of the maze. They have multiple boxes that they can go to. Only one of these escape hatches has a box, and they've been trained on this maze pre-injury. And what we find is that our sham animals can get to this escape hatch relatively quickly. TBI plus hemorrhage, when we treat with saline, these animals have a significantly increased escape latency, meaning they take longer to find that box, and this is significantly decreased in the GM-CSF. Or it's not significantly decreased from saline, but it's not significantly different from our sham-treated animals. We've also looked at adaptive immune response. Another drug that we use clinically are checkpoint inhibitors. So we've used anti-PD ligand 1 antibody. PD-1 is a molecule known to have an interaction with PD ligand 1, and it leads to T cell downregulation. In this study, we injured the animals treated with anti-PD ligand 1 antibody at 2 separate doses over 7 days, giving a total of 7 doses, the first dose giving immediately after injury. And again, we looked for systemic immune function and evidence of neuroinflammation. In the whole blood, again, you can see a baseline of TNF-alpha production capacity. In our sham-treated animals, this significantly decreases in our animals treated with our combined injury plus saline. This is at post-injury 7 days. And this is reversed completely in our animals that are treated with 100 micrograms of anti-PD ligand 1, but not 10 micrograms. And again, you can see similar results when we look at the spleens. Unfortunately, when we looked at brain immunohistochemistry with the anti-PD ligand 1 antibodies, what we found was that in that 100 microgram dose, we were seeing significantly increased IBA1 positive cells. These are our microglia as compared to our saline-treated injured animals. And we were also seeing significant increases in number of astrocytes. Additionally, when we did our Barnes maze testing looking at neurocognitive function, what we found was that this dose of 100 micrograms of anti-PD ligand 1 antibody caused a significant increase as compared to sham, and similar results as compared to completely untreated animals. So my conclusions from the studies that we've done so far, this combined injury definitely leads to systemic immunosuppression. Both the GM-CSF, the innate immune modulator, and the adaptive immune modulator, anti-PD ligand 1 antibody at the higher dose, preserve immune function following that systemic injury. But the anti-PD ligand 1 antibody is associated with increased neuroinflammation. The future directions of our lab are to look at animal model testing using IFN gamma and IL-7, and then to start doing clinical studies using GM-CSF in TBI patients with verified systemic immune suppression, and looking at these patients with serial immune function testing, neuropsychiatric testing, and radiographic testing to ensure safety and efficacy of this drug. And in closing, I just want to thank my lab members, my mentorship, and especially my partners. In particular, these studies could not be done without Dr. Gaith Bahadur, who's originally from Iraq and immigrated to the United States and has been just absolutely instrumental in my lab as a research scientist. Thank you again for the opportunity to present this research.
Thank you very much, Professor Sribnik. Can I also request Professor Sribnik and Professor Figaji to stay on for a discussion after the next speaker's talk? For our next speaker, I would like to invite Dr. Adrian Caceres. I don't know if I'm pronouncing your name correctly. My apologies if I'm not. But Dr. Adrian will talk about ICP monitoring in pediatrics and controversies.
Thank you so much. I'm going to share my screen. Can you hear me?
Yes, we can hear you.
Okay, hold on.
I'll let you know when we can see your screen as well.
Okay. All right.
It's up. We can see it now.
Right? Okay.
Yeah.
So I would like first to thank to be part of this interesting panel and part of this activity. And with that, I will like to tell you that I have no financial gains from what I'm about to tell you. So what is the role of ICP monitoring in children? Well, as you know, there has been a number of studies that have led to the guidelines for the management of pediatric severe head injury. And that based on the data that has been recollected, the degree of certainty for recommendation of ICP monitoring and CSF management has come out as class 3 evidence. We know that it does improve the overall outcome of traumatic brain injury. And of course, in every neurosurgeon's mind, the fact that if we know what is going on pressure-wise within the skull, then things should be more controlled, right? However, there are many confounding factors of why is it that we're still dealing with class 3 evidence, and that's what I want to talk about. Of course, over the years, our environment for treating children with severe head injury has become more and more complex, not only within the hospital, but outside the boundaries of the hospital. Pre-hospital care is getting better and better in many places around the world. But there are so many confounding factors that in order to analyze one single thing that we do is not that easy. We know, of course, that if you plot morbidity and mortality in a time lapse, we have two phases: the primary injury with either hematomas, contusions, or diffuse injury, which will lead to increase of the intracerebral pressure, and that will give rise to either hypoxia or ischemia or hypotension as a result of associated injuries. And these will lead to secondary insults, which will produce on their own all of these mechanisms. Tony has spoken a little bit about this. I will not go deeply into this because this would be just a single talk by it, but there are so many new things that we're learning that happens at the cellular and molecular level that does not only affect the immediate, but the long-term outcome of these patients. And of course, we're now trying to understand how we can do our intervention in all of these phases. So what are the simultaneous factors that confound ICP monitoring? Well, better per-hospital care. Some of these patients are either intubated at the site of the injury, or sometimes in order for them to be transported to a class 3 trauma hospital center, they're intubated prophylactically, in order to make sure that the transport is going to go more smoothly. Also, there's aggressive treatment of hypolemia and hypotension. Some kids are even given osmolar therapies even before they reach the hospital. And of course, CT imaging is becoming more and more widespread, so we're able to know which kids should go well. And of course, in the long run, some other things such as enteral and parenteral nutrition can be of impact. What we do know is that the sustained elevation of ICP is a key pathophysiological variable in the occurrence of secondary brain injury following the traumatic brain injury. Now, let me show you this image. Would you agree that this child needs ICP monitoring if the child shows up to the emergency room at your hospital center with a GCS of 5? I think most of you would agree that yes, it does need ICP monitoring. Well, it becomes creepy or difficult to make the decision when that child shows up with the same imaging at GCS3. And everybody would, in some centers, they would say, yes, we'll still put an ICP monitor because we need to document legally what is going on in a center. But in some environments where you're constrained by economic factors and you don't have fibers for everyone, you might say, this is GCS3, the image looks really compelling that this child will not recover. I will not do it. So these are the things that come into play. Of course, when we see images like this, when you have infarcts in the basal ganglia because of damage, then probably the decision not to monitor ICP would be more easy and more straightforward. But of course, we know that there is a variation in therapy and outcomes for ICP monitoring. And the most interesting thing is that we should keep in mind that hypotension and hypoxemia, as shown in the traumatic data coma bank, are the main drivers for bad outcomes. So you should avoid at all means these two factors. And we know that after traumatic brain injury, intracranial hypertension and systemic hypertension is very bad. So that's what you should pursue. And of course, you can, there's also a discussion, and this would be a completely whole different talk if we want to decide if you want to go via ICP or CPP, right? But we know that even if you go by both ways, the outcome will be better. What is the problem with studies regarding ICP and their outcomes? Well, sometimes there's a small sample size, there's inadequate measurement of the severity, the codes come in different formats. The mortality is the only outcome in many of these studies, and there is a lack of uniformity whenever you cluster patients by hospital. But look, this is very interesting. Why is it that only less than 60% of patients with traumatic brain injury are being monitored in the UK, and then in the US, in some places, it does not even reach 30%. And in North Carolina, in a study done in children less than 2 years, less than 1/3 only went on to receive ICP monitoring. And what are the main reasons for not placing an ICP monitor? Well, it seems that nowadays we find more adolescents that come in either in post-ictal state or are intoxicated, and then it's hard to make a decision by those who are looking at the patients. Some of the patients that initially were classified as a lower GCS score actually do improve on their way to the hospital. Some other surgeons will consider that, yes, this patient has a hematoma, but I'm pretty sure that if I'm very straightforward and drain the hematoma, the child will recover without any major issues. Therefore, I don't need to monitor ICP, right? Because it looks like he's going to do fine because the time of the injury and the drainage are really close. Sometimes, some of the patient like this, you would decide, no, this is not worth ICP monitoring. I will just take the hematoma out. But sometimes on some of the patients, like I stated before, there's devastating image that some surgeons might choose not to waste an ICP fiber in an economically constrained. Or sometimes you have a moribund patient. Sometimes you're dealing with infants and you're not sure whether you're going to place the fiber and whether that's going to be useful. And this is something that sometimes is a widespread thinking. And of course, in many systems, it's not documented if you are placing ICP monitoring. So that makes it hard. So when you take patients as a unit of measure, hospital as a unit of measure, and you try to associate, we always end up with class 3 recommendations. But I think the main questions are the kids with severe traumatic brain injury at the risk of intracranial hypertension. Well, we know that diffuse cerebral swelling in a CAT scan is 75 specific for the presence of intracranial hypertension, and that 1/3 of the kids who had an initial ICP measurement greater than 20 at some point will require intensive care and measures in order to lower that, and that it would be more prevalent to have spontaneous motor function is not demonstrated in kids who have raised compared to those who doesn't. So let me move from here. So the data that we have obtained, are they useful in management children with severe traumatic brain injury. So there are 15 studies that involve almost 900 patients that associated intracranial hypertension with poor neurological outcome or death. And from one of these studies, this is a very interesting paper, we do know that, yes, we know that the patients who go on to be monitored, of course, we're doing a lot more of things to them, and their hospital stay is really longer. But the confounding factor is that sometimes we cannot demonstrate a significant difference in between those who were monitored and those who did not. So in this study that was published in JAMA Pediatrics, we found that when a propensity-weighted logistic regression model was done in almost 3,000 children, we were not able to tell a significant difference in the functional survival between the groups. And there was no significant association also between monitoring and hospital mortality. And we do know that those kids who have ICP monitoring probably have greater treatment intensity than those patients where we're flying blindfolded. So when we look at all these variables and what is it that we do, of course, kids that are monitored do go on to receive more intensive care. And I think one of the most interesting things is that once you put that monitoring, then it needs to be vigilated. So in the interesting of time, I think that we know that within the predictors of intracranial hypertension in children, roughly 85% of kids with ICP monitoring receive therapy to treat intracranial hypertension. And of course, the significant predictors is that if the patient had a hypoxia prior to arrival to ICU, they're female sex or have a higher injury severity score, of course, they're more prone to have greater injury. So I think the recommendations here is that the decision to insert and use any monitoring device depends on the understanding of the data and the information derived from that monitor. I remember the time, and we discussed this with Tony Figaggi when we were looking at interstitial oxygen, and the numbers were just too many, and not everybody understood those numbers. And sometimes in some centers, people even didn't want to look at the numbers because the interventions were so many at such short time frames that some people chose just to look at the average after a few couple of hours and not be doing like minute-to-minute intervention. But I think IC monitoring is here to stay. We need to do randomized. I think we need to pull data from many centers across the globe to prove that the best way to know is the more data that we have, we will understand more the outcomes and the factors that influence the final outcomes of kids with severe head injury. And with that, I would like to thank every one of you.
Thank you very much for that great talk. I know that we have a discussion at this time. I'm just wondering, Dr. Salman, do we have time for that, or should we keep moving?
Sure, we can have short discussion.
Sounds good. I really enjoyed all the talks so far, and I really appreciate the speakers' flexibility just in terms of being here. Just looking at some of the questions through the chat, one thing that came up just in general, ICP monitoring. I know you touched on this, Dr. Caceres, but also interested in everyone else's opinion too. But does ICP monitoring improve long-term outcomes in your opinion for pediatric TBI? Or is it just guiding short-term treatments, do you think?
Well, I think there is a little bit of the patients that we choose not to monitor probably have worse outcomes, and some of them die, right? So we cannot tell what the functional outcome of those patients was eventually going to be because, like I said, the endpoint for most of these is mortality, right? Once the patient is dead, you cannot measure outcomes. So from those which you place the monitor and you treat it, of course, some of these kids, nevertheless, even if you rescue them, will have bad outcomes. But I think the main thing is that if you do not monitor the numbers, those children are more prone to suffer, hypoxia, more injury to the brain, And I think where all this data is really interesting. I would like to ask Tony what his take is, on the current, when you associate ICP monitoring with LICOX, what is his final say? Because this has been an ongoing discussion from, I guess, more than 20 years, right, Tony?
Sure. I mean, I use both. So the more information that I have about the underlying physiology, the better I think my decisions are about how to treat it. So, so as I said, I think intracranial pressure is always my first go-to, but I just think where you have capacity to have a little bit more information, because especially in children, because sometimes it's hyperemia, and I'll tolerate an ICP of kind of 20, 21, 22 in a completely different, with a completely different approach than in a patient who's got a brain oxygenation of 10 millimeters of mercury with the same intracranial pressure. And as I said, the changes in CO2 and the changes in blood pressure have very variable association, very variable effects on both intracranial pressure and brain oxygenation. So for me, I think it just gives me that little bit of extra edge in terms of trying to make a little bit more of an informed decision. And then if I can just piggyback on one of those questions about whether ICP monitoring changes outcome, again, like I said in my lecture, the ICP monitor itself can't do anything. It's all about what we do in response to that number. If we do silly things, then it's not going to benefit patients, it's going to harm them. So that's the first thing. And one of the problems with the literature, and you see this a little bit more in the US, is that there are several publications that take these large trauma databases. I think there's called the TQIP database, Eric, in the US, and often general surgeons publish these articles. And then they take everybody and then they look at those who had ICP monitors and those who didn't have ICP monitors. And very often the ones who did have ICP monitors are a little bit worse off. But the problem is there's no way in that database that they can control for the reason that people put ICP monitors in. And almost invariably, those are more severely injured patients. And the severity of the injuries just doesn't come through in the database. And I really do wish that journals would stop publishing it because it's so incredibly misleading. So that's my rant for the day.
I would echo everything that both Dr. Caceres and Dr. Fagaji said. Tony, when I look at those database trials that you're talking about, I mean, what the first thing that comes to mind is garbage in, garbage out. And to echo what I think Dr. Caceres was speaking about, there's just a huge selection bias in those databases, which kind of invalidates the results. The other thing that I would say that we've used, we don't use LICOX in our ICU, but we have been using PRX after reading, especially some of Dr. Fagaji's manuscripts on that. And we found that to be quite effective in terms of trying to manage CPP for optimal outcome.
Hi, Tony and Adrian. I think the brain monitoring for ICP depends also from the age. Could you talk a little about the monitoring, the need and method of monitoring by children in the first 2 years of age?
That's even trickier, Arthur, because everybody will tell you that, of course, there are certain things. Well, number one is that I think as we're aging and getting more data, we realize that the old cookbook recipes for intracranial pressure and metabolism is just not the reality. Those data were very valuable, but not always applicable, because sometimes we see kids with a shunt malfunction who have ICP of 60 and are running around like nothing. Of course, trauma is a completely different deal, but of course, we still do not know what the adequate CPP is for kids 2 and younger, right? We try to imply that from adult numbers, but it's really hard to tell, especially those kids under 2. And of course, kids who have been subjected to non-traumatic injury, shaken baby syndrome, those are different from high-speed injury or the other classes of falls and so on. It's very complex to start dividing all these categories and analyzing each of them. And that's why we need to do more collaborative studies.
Maybe if I can add a comment, if it comes to the costs and limited resources, maybe also the role of an EVD should be defined, because it's one of the cheapest way to measure and also to treat ICP.
Yes, at least in our center, most of the time they go hand in hand. But I do not know of a study which has looked, because sometimes, especially in kids who have severe brain edema, some surgeons will hesitate to put an EVD, because they fear that they will not hit the small ventricles, or that sometimes they will enter the ventricle, you squirt a little bit of CSF and it's done. In our center, we believe that every single drop that comes out is at least one single drop that you have to deal with. But this is not everybody's opinion. Old school, it's impressive how it models the conduct of so many surgeons around the globe. Some people are very hesitant to put an EVD, right? Especially with edema.
Thank you so much for the discussion and for everyone's input. I just wanted to ask Dr. Blount is here as well. If he wanted to make just a few comments, he asked before we move on to the interview very quickly.
I just wanted, on behalf of ISPN Education, to thank the speakers this morning for their flexibility. Hassan, you've already done some of that, but on me was a confusion on our day, and we were originally thinking we were talking on Sunday, and it was earlier in this week that we realized the error. And I want to specifically call out Adrian, my partner, Arthur, and Tony for their remarkable flexibility, dedication, contribution this morning. So thank you for your flexibility. For the audience, I want them to realize how accomplished these leaders are in ISPN, and that we're very grateful to have them here to participate in this. And finally, that ISPN very much values the collaboration with WFNS to participate in pediatric activities, and congratulations to the organizers and moderators for this very good session. So thank you on behalf of ISPN. We're very grateful for the opportunity to partner and endorse this course as a sanctioned ISPN educational activity. And thanks to my friends and colleagues for their flexibility and consistently excellent presentations.
Thank you so much. Dr. Shamim, do you want to introduce the next speaker?
Oh, so I thought you were going to introduce
No, I'm happy to. Absolutely. So Dr. Budnick is here joining us. She's going to lead the session with an interview with a legend. So I'll turn it over to you.
Hello. I'm honored today to be here to interview a legend, Dr. D'Acunha. I think I speak for everybody when I say how much of an honor it is that you would take time out of your busy schedule to impart some of your wisdom. I think some of these questions are more broad in the pediatric neurosurgery realm and not just neurotrauma, but of course can be applied to the neurotrauma field as well. So in your expert opinion, what do you think the vision is for the evolving role of the young neurosurgeon in the next decade, particularly in pediatric neurosurgery?
Okay, first of all, I don't feel me as legend. Yes? Okay, thank you for your question. However, I find it quite broad and open to various interpretations depending on the context. I am particularly concerned about the development of young neurosurgeons in both underdeveloped and developing countries. In underdeveloped countries, there is a significant lack of resources for practicing modern, efficient, and safe neurosurgery. In developing country, the situation is complicated by unchecked increase in the number of new neurosurgeons, the rapid establishment of new neurosurgery residence program, and poor geographic distribution. This concentration in large cities can lead to low wage and potential result in the future unemployment for many young neurosurgeons. This is the situation, for example, in our country, in Brazil. This is really very difficult because there's no plan about the future of the all medical specialty, especially in neurosurgery.
Okay. Thank you for that. And how important do you think, I mean, you spoke about in the developing countries and developed countries, how important do you think global collaboration and mentorship are in developing the careers of those young neurosurgeons that are, going to become the legends?
I think the advancement in knowledge and technology do not occur at the same rate across all countries, or even in different regions within a single country. This is where collaboration and mentoring play a crucial role. The democratization of knowledge become accessible to all neurosurgeons, particularly those just starting their career in the specialty. I believe that experienced neurosurgeons have a responsibility to guide younger professionals, help them navigate the evolving landscape of the field. They should encourage education and research and instill the importance of preparing the next generation of neurosurgeons. So I think the global collaboration and the mentorship is really very, very important for the future career of young neurosurgeons.
Thank you. And what challenges do you think those young neurosurgeons are going to face, especially in these healthcare systems that are constantly evolving and patient experiences and expectations that are evolving as well?
Wow, this question is easy to address. Young neurosurgeons must prepare to adapt to societal change, including the contradiction that will arise from these developments. For instance, healthcare systems are evolving to demand greater efficiency at lower cost, while technological advancement requires substantial investment. New technology can be very, very, very expensive. Patients are coming to, on the other hand, patients are coming to your office more informed. So young colleagues need to be well prepared to provide confident answers and guidance.
That's a great point. And do you think that there are other ways that a young neurosurgeon can contribute earlier in their career beyond the operating room?
That is an excellent question. Performance in the operating room stems from extensive research, studies, discussion, and broad participation in decision-making. Medicine requires ongoing training and the exchange of experience. Organize and update that data enable research which can either validate or disprove existing knowledge and practices. Educating young neurosurgeons not only allows them to continually review their knowledge, but also helps them acquire new ideas. It is important to encourage young professionals to engage in discussion about health policy and global health, and to join institutions that contribute to this policy. I want to emphasize the significance of regional institutions, medical councils, as well as regional, national, and continental medical society. Global organizations such as World Federation of Neurosurgical Society play a crucial role as well. As a pediatric neurosurgeon, because I am pediatric neurosurgeon, I particularly value the work of the International Society of Pediatric Neurosurgery, ISPN. The ISPN, through its dysraphism working group, has been making remarkable effort with government in various countries to prevent dysraphism by advocating for laws that mandate the addition of folic acid to foods. This exemplifies the strength of a reputable institution which relies on the participation and enthusiasm of young neurosurgeons.
Thank you so much for that insight. I think in particular, in terms of pediatric neurosurgery, where do you think some of the major gaps that some young neurosurgeons could spend their extra time trying to fill in the research department?
Oh my God, this is a very important point, because the young neurosurgeon need to be together with the leader, with the guide of the service, to develop experience, to develop research, to participate with effort in all work in the clinic, and think that they work with young patients, that everything what we do with a young patient, that means have a consequence for the whole life. That I think is really very important.
That's a great point. And finally, is there anything in particular in the last few years that you've implemented in your own hospital that you feel like, oh man, I wish that we've been doing this for the last 20 years?
So in the last couple of years, we implemented in our hospital in Recife, in the northeast from Brazil, we implemented a fellowship program in pediatric neurosurgery, yes. And we have a project that up next year, we start with 6-year residence in the neurosurgery, in the pediatric neurosurgery. That I think bring better results in the formation of the pediatric neurosurgeon in our country, in a country that we have more than 40% of the population under 18 years old.
Well, that's great. I'm sure that that development will be invaluable to those trainees. So I just want to thank you for taking the time again to impart your wisdom. I'm sure everybody is taking a lot of notes. I appreciate it.
Thank you so much, and we are together. Thank you.
Thank you, Professor Cunha, for those excellent pearls of wisdom and the insight, and your interview clearly reflects why you've been chosen as a legend to be interviewed. I would now request my fellow moderator to thank all the presenters and then close this session.
Thank you.
Thank you again, everybody. We'll try to keep up with the schedule, and I think we have the YNS panel discussion next. We have, if Dr. Bendock is here, and Dr. Satova, who will join the panel.
Yes, we are here.
Okay, and I may join on because I think Dr. Bendock may not be present right now.
Yeah, I think he had to go, so the time he had given to us was just passed away, so it's fine. So I think maybe Hassan Sayed and Nargiza could do this session for us, please.
One more time, hello everyone. It's a great honor to be here today, and let us to open the discussion of YNS, improving of neurosurgical training. So today we will have our colleagues and speakers who will discuss from Pakistan, USA, Germany, Rwanda, Indonesia. So 4 different continents with 4 different, let's say, neurosurgical training. And if we can put discussion and stay in line with the few aspects as theoretical knowledge, which we are getting while doing neurosurgical residency, gaining the skills inside the operation room, access to the simulators and cadavers, to the lab training, and how fast you can go to your own independent practice, where we could talk about the role of the mentor and how fast you can learn from him and later on go on your own way. So today we will have Dr. Afifa, Dr. Ashwin, Dr. Farha, Clary, and Selfie. I hope I pronounce all names and surnames correctly. So if...
Hello, Dr. Nargisa. May I start?
Yes.
Okay, thank you very much. First of all, Professor Salman Sharif for organizing, and thank you very much to all participants to take the time to listen to us and make it possible to make a platform for discussion at least. Thank you very much to Professor Salman Sharif. I would like to just quickly share my screen. Is it visible, Nargis?
We are waiting. Now it's visible, yes.
Okay. So regarding the neurosurgical training in Germany, I would like to say some few words. So it is a long path, but even though it is possible to finish, as a foreign doctor or the German doctors, they have to finish their medical license exam, and as a foreign doctor, they have to pass their C1 German language. Then they are welcome to join to the surgical training, which is for 6 years. And there are some few hospitals which offer full 6 years, that means 72 months of training. And after the training, one have to finish their logbook. Even 6 years is finished, there might be possible that logbook is not yet finished. It is not new. It is very common in Germany. So as you see, I pass all this hardship, and that's why I am having a certificate. So after this, one should go through, once the logbook is finished, go for the specialized exam, and that also have to fulfill some logbook curriculum and also some extra training for that. And for maintaining harmony between the all European Union, there is a standard which is always maintained also in Germany. So there are some, like Professor Thorn, who used to be the head of the department in Klinikum Grosshaden, also write on journal of the standard of neurosurgical training for us. There is also a protocol how to maintain the logbook. So there is also some plan and programs is always there, what a resident should know, like patient documentation, management, safety, secrecy, privacy, and like everything is written and everything should be followed A to Z. That's how is our training in Germany. There was an old curriculum, that the traditional one, which is divided into 7 years, that what should be done on the first year of training, second year, and the third year, which is actually very nicely modified, and it is now changed to that on the first year even we are allowed to go to the ICU. On the second year we take care of our functional and all the emergency. Third year is the spinal. Fourth year is the research parallel to the clinical work. On the fifth year we are assist skull base, pituitary, complex spine, and sixth year neuro-oncology, and seventh year we are allowed under supervision to do some surgical approaches, but definitely under supervision. There is a big list of curriculum what we have to fulfill within our 7 years of training, which include neurology, neurophysiology, neurotraumatology, neuroradiology, neuropathology, spinal neurosurgery, peripheral nerve rehabilitation, stereotactic and neurological approaches, epileptic surgery, intensive care, neuro-oncology, pediatric neurosurgery,
Sorry,
vascular
Farah, you're taken away 5 minutes. There are 4 of you, so I
Okay,
think
sir.
give.
Thank you very much for the remind because the process is so long.
No,
Maybe
we
that's
don't have to.
why.
We don't need to know the process. We need to know how to improve our training.
Okay, sir. So if we know the problem, then we can come to the solution. So I take care from the study and the survey, which is very recent, 2023 to 2025. So the main problems are that uncontrolled increase of the neurosurgeon, irrespective of the neurosurgical center, and lack of flexible working condition because it is always centralized. That means the university hospitals gets most of the cases. So who are not centralized, they are not getting much cases. Less case means it takes a longer time to fulfill the logbook, and that's how 6-year training get longer. And some fact check about the current situation. There are 1,000 neurosurgical residents, whereas we don't have 1,000 hospitals. So we understand the problem, which is totally survey and fact-based. So what are the solution then? So we have to increase
Can
or
we leave it
regulate.
for somebody else, Farah, to give the solution
Yeah.
since it's now 7 minutes gone? So we have to leave
Yeah.
some time for everybody, please.
Dr.
Yes.
Afifa, maybe you can continue. Dr. Afifa and Dr. Ashwin.
I'm here. I can go very quickly if you.
Yes, sir. Please.
Hi, thank you so much for having me. I'm Ashwin Ramaya. I'm an assistant professor at Stanford Neurosurgery. So I appreciate the opportunity to speak to you today. It's a great setting here. So there are a few themes I identified that I hope will be common across the audience in how to improve training in neurosurgery in this very, very dynamic landscape. But there's some things that I think are constant. Number one is this idea of general training versus specialty focus, right? So this is something that my personal opinion, and I think many of you will share, is that you have to be a neurosurgeon first and then a specialist second. So I think it's really, really important during training to get as much broad experience as possible because you never know what you're going to be called on to do. And second, there's a lot of cross-pollination. Things from one discipline are critically important in innovating and in actually providing excellent care in other disciplines. So I think it's really, really important during training to maintain a general focus rather than diving into a specialization too early. That being said, it's certainly important to ultimately specialize and keep that as a focus as well. The second theme is practice setting. This is one thing I think certainly in my training, I had a very limited exposure to various practice settings. I was trained at an academic center at University of Pennsylvania, which was fantastic, but I didn't really get a flavor of what practice was like in a private practice setting. It was just very, very an academic center, and I know practice, the way care is delivered in a private practice setting and in a rural setting, and certainly in the global setting, is very different from the care the healthcare delivery system I experienced during training. To whatever extent it's possible to increase exposure to wide variety of practice settings, I think that that can be very beneficial for trainees. And finally, and maybe most pertinent to our present moment in time, is how to deal with technology, right? So there's such a dramatic increase in the power of tools such as large language models. And I think there's always a tension in between making sure trainees are exposed and become masters of these new tools so that they can be authorities and not be dependent on these tools. But at the same time, I think it's really, really critical to have not depend on the tools to generate a foundation of knowledge or foundation of skills. And so I think that is an important concept to keep in mind is start first with the basics. Imagine that you don't have the technology, and only once you've gained some expertise in the foundational knowledge, then you start incorporating the technology. So I'll end there and hope that resonates across the audience.
Thank you so much. I see we have Dr. Claire and Dr. Selfie online. So Dr. Claire, you could give your comments.
Yeah, I can go ahead. So I'm Dr. Claire Karekezi from Kigali, Rwanda. I will not speak on the Rwandan perspective, but I will speak on the African perspective. So Africa, which is probably one of the youngest continent to have, like improved neurosurgery and neurosurgical care, has around maybe 2,000 neurosurgeons. So Africa in the last 15 years has focused on training neurosurgeons. And this started more as training hubs because not all countries could train neurosurgeons in their countries. And now where we are, we have at least half of the countries that have at least a training program. And we kept those training hubs. So some countries have made it very well. So like Egypt, Morocco, Senegal, Kenya, Zimbabwe, South Africa, they have really added to the training and helping training neurosurgeons from other countries. And we had developed colleges. So we have the West African College of Surgeons, which trains neurosurgeons as well. And we have the College of Surgeons of East, Central, and Southern Africa that contributes to the training of neurosurgeons. So now when you look at the general training of neurosurgeons, this has pretty much increased. Like, general neurosurgery is pretty much well done right now. But when you go to the subspecialty training, and that's where we're going, like those complex tumors, complex vascular cases, complex spine cases. When you ask young African neurosurgeons, what do you want? They will tell you, I want to be able, to clip a nice, aneurysm like Michael Lawton. I want to be able to do a nice spine like Dr. Salman Sharif. I want to do a nice skull-based tumor without killing the patient. So they really want those specialized training, and they need help. So there has been a lot of partnership between HIC and LMICs, local partnerships, South, and there is, a lot of webinars, courses happening, training happening. So we're seeing the training taking another stage and, going more to the subspecialty training. I would say one last word that maybe academia and research is still a little bit slow, but we also need to improve that part. And, I'm looking forward to discuss more solutions with the others. Thank you.
Thank you so much. And Dr. Selfie, would you like to add something?
Yes, thank you very much for the opportunity.
I think I'll go next.
Can you hear me clearly? Yes, thank you. I just have maybe a couple of this is short slide, if I can share. So I come from Indonesia. Indonesia is a very unique. We have 17,000 islands, and can you see my screen?
Yes, we can see your screen, not full screen, but yes.
Oh, okay. So it's a very unique where we have more than 17,000 islands. So this is the distribution of the neurosurgeon in our country. So we still lack in number, but we also lack in distribution. So before we discuss about the training, so then we need to understand where we are and where we are going to work and what we will have after we finish the training. And this is the curriculum. I think I'll just skip that. And then the number of cases. I think some of the other presenters already mentioned that number of cases is very important. So it's not only the timing, like it's not only 5 years, 6 years, or 7 years, but it's the number of cases that are being faced by the training that will help the trainers to become a better neurosurgeon. And since 2024, we just recently opened a fellowship training, which before we don't have any. So usually what we did was that we sent the surgeon abroad and then came back, and then they will have the fellowship or subspecialization title. But now we start to open the fellowship training in the country for 6 months. And how to improve? So I think I will just skip some of this that already mentioned by the previous presenter. So as we know that the cadaver dissection is very important, how about the simulators and also the simulation for crisis management? For example, the one thing that maybe if one of the audience here that goes to the North American Skull-Base Society meeting, that Dr. Gabriel Zada has beautifully made a very beautiful model about the ICA injury during the endoscopic procedure. And I think that kind of training is very important, and it will improve significantly in the neurosurgery training. And also the stepwise approach for observation, assisting, and partial procedure. I think this sometimes it will be varies between the consultant, but if it becomes standardized, then it will be better for the residents. And then the real-time video recording and debriefing, and then practice on specific steps. And some of us already talked about the protected time for academic and research, which is not very easy in our country to find those times. And I think what I would like to emphasize is also about the interdisciplinary and team training, because as we know, when we finish, we are not gonna only do the procedure just by ourselves. For example, for the skull-base or endoscopic procedure, we will have the ENT, or we need to have the plastic surgeon, the oncology, radiology, and for the complex procedure. And also, for example, for awake anatomy, we will have to work with the neurobehavior from neurologists or from the neuropsychologist. So if we include this in the training, then I would suggest, I would think that it will be better when we finish, then we know how to build our practice since the very beginning we become a neurosurgeon. And I think this is what we are doing right now, the global exposure and also fellowship. So the short-term observership and also the fellowship is very important. I think for me, myself, and I think I can also speak for Claire, that during the fellowship time where we spend 1 year abroad, we learn about the system, we learn exactly how the work there, and then when we came back, we try to apply, and then we try to send more and more of our colleagues to go abroad and learn, and then we can build that together. I think that's the one thing that the WFNS and all this organization should work on in the names of the global neurosurgery.
Thanks, Selfie. I think let Afifa go. It's only 1 minute left, 46 seconds.
Yeah. Yes, maybe we can ask Dr. Afifa to share her experience and comments.
All right, can you guys see my screen?
Yes, I can see we can see your screen.
So good evening, everyone. Firstly, I would like to thank all of you for sparing out time and having this great discussion and coming on board. So since obviously the rest of the peers have already discussed on the basic training program outlines in their regions, so I would not go on those details because the topic was how to improve the neurosurgical training, and how to improve neurosurgical training basically comes as a global perspective where we're talking about. So we're not really confining ourselves to one area of the world or one part of the world. So naturally, we know that our future directions need to be that there is a significant lacking between structured national and international neurosurgery curriculum. And so we need to everybody so that there is less of a disparity, because there are areas of the world where there is a training program which is like constituting of 4 years of neurosurgery training, whereas there are areas of the world where the training program constitutes of like 7 to 8 years. And as Farah and rest of the peers also identified that the logbook cases are not completed. So yes, there is a significant disparity between the exposure of cases as well between the LMICs and the developed nations, obviously, because there is a significant amount of pediatric neurosurgical cases that are not, and the diseases that are not really prevalent in that part of the world. So obviously those people, they lack that kind of insight towards dealing that particular aspect of neurosurgery. Also, we would like to, because of the enhancing the future directions, would be encouraging global partnerships and exchange programs, because as part of WFNS, we have training and exchange programs that contribute with the development countries of the and facilitating bridging between the developed nations as well. And also, there's an insight we need to promote subspecialty trainings and fellowships locally as well as globally. And yeah, there has to be a much more increased focus on research building. The onset and advent of simulators and skill labs, because now as we're progressing, so previously it was more of a cadaveric dissection kind of an era. Now we have simulators. So yes, in the LMICs, we have lack of resources, so we don't have that kind of simulators available, but I think we should try and invest more, because that is different. The set of upsurge models and surgeons labs, these are new technologies that we need to
I think, Nargisa, we need to wrap up.
But we have to wrap up. Yes, I just want to tell thank you very much for your comments. And one more comment I want to give: if for some reason your country is not able to provide you
more rare and sequence of that possibility, I think that.
Thank you so much, Dr. Afifa. I just want to give the last comment. If for some reason your country is not able to provide you all important training or the training you need personally, you should be highly motivated and always join social media webinars. First of all, from WFNS, they are all for free, and it's all up to you whether you want to spare 1.5 hours for your own good, then you should do good networking, find professors, don't hesitate to text them, save some money for workshop, at least 1 or 2. And it's all about how we want to improve ourselves. Thank you so much. I think, Professor Salman, we can close this discussion and go on for the next speaker.
Maybe Hassan Sayed, could you please introduce Professor Michael Lawton?
Sure, absolutely. It's really an honor to introduce Dr. Lawton. I'm sure he doesn't remember, but back in 2009, when I did my rotations, one of the rotations at UCSF, when Dr. Eddie Chang was a chief resident, and I got to observe his surgeries, which were amazing. But really, he doesn't need an introduction, but I will give one. Sorry, can you hear me? But Dr. Lawton is president and CEO of Barrow Neurological Institute. He specializes in cerebrovascular disorders and skull-based tumors. We all know he's a prolific author with his series of books and technical descriptions. He's also known for his work in global neurosurgery as a co-founder of Mission Brain. We're really fortunate to have him here, and he will be discussing aneurysm surgery.
Well, thank you, Hassan. Yeah, your comments brought back to me your visit. It has been quite a while. Okay, can you see my screen?
Yes, we can see.
Okay, I thought I would just start by just sharing a few thoughts on the state of training, because I think that's the topic of interest. And just so I'm clear, how much time would you like me to fill here?
Take your time, Mike. It's fine.
Okay. So these are just some thoughts on the state of education, the state of training, and thoughts on how we might, as a collective body, improve that. So I do think there's steady interest among all of you in training to gain open vascular competencies. These are kind of, in my biased opinion, what pull a lot of medical students into neurosurgery, is to see these really elegant vascular cases. And so they see the brain, they see the arteries, they do these microsurgical dissections that are I think, just different than brain tumor resections or spine cases. So there's real interest there. It's also true that we have an increasing number of residents. We've, as a program at Barrow, been always the number one largest program in the country with 4 residents, but now there are probably a half a dozen programs that have 4 residents per year. So all programs are growing. The numbers of residents is increasing. So what's happening is we're trying to learn the same skill set with less cases and also with more complexity. The cases that do come to surgery are harder. So that compromises the resident autonomy and involvement in the case. There's this competition between open microsurgery and endovascular. And so there's an increased importance on outcomes, and that affects the state of education and training. I think there's a limited number of training substitutes or simulators. I do think that forever cadaver dissection will be one of the most invaluable resources, but those are expensive and not always accessible to those around the world trying to get cadaver experience. But things like bypass techniques are really something that is available. You can go and get a chicken wing or a turkey breast from the market, and you can dissect out the artery and do your bypass practice techniques on something as cheap and available as that. Learning through observerships has always been a part of neurosurgery. If you think back to all the people that used to go visit Ghazi Yazergil in Zurich and watch in his OR, that idea of traveling observerships is becoming less common. I think people realize the cost, the difficulty, and so that whole tradition in neurosurgery is becoming less common. So, when it comes to education, my view is like pop stars or rock stars. These are the 4 Led Zeppelin albums that I listened to as a kid. But whether you're a Zeppelin fan, a Taylor Swift fan, or a Rolling Stone fan, I think to remain relevant as a teacher, you have to keep producing. And so, I've always tried to have that philosophy, and these are some of the books. I'm really excited to tell you that 7 Cavernomas is on its way to the printer. It will be available for the first time at the Congress of Neurological Surgeons meeting in Los Angeles in 2 months. So I'm excited to see that, excited to share that. But I do think, for this idea of getting surgeons with experience to express themselves, to boil down that precious wisdom into things that are on paper that can be easily transmitted and shared is really an important thing that we've got to do. This is a quote from one of my former fellows, observers from Ireland, and I'll just share with you. She said, I started working as a vascular neurosurgeon in Ireland, and yesterday I split the fissure for a clipping for the first time. On the desk in the theater was 7 aneurysms, which I used to prepare. We did an AVM a week ago. 7 AVMs was in my hands that day. On Monday, we're doing a bypass, and 7 bypass is in my computer right now to prepare. So I think that as an author, you don't always get this. You publish papers, and it goes off into the internet or onto the pages of the next journal, and you don't always get this feedback. But I think it's really nice to see the power of the pen, which I've always believed is more powerful than the scalpel, because you reach more people and have a bigger impact by sharing knowledge. This is really meant to talk about teaching technique. We've created this environment, the Eller Telepresence room in Barrow, where we have a small 45-seat theater in the round. You can get people very close to you, and what you see here is a teleprompter. So I'm able to actually draw schematics, really do kind of the X's and O's of neurosurgery, and teach in a way that's really different. It's not like anything that I learned when I was a resident trying to train myself. this is a whole new technique. And I think this idea of using novel teaching techniques is really important. This is from one of our conferences. This is Rokuya Tanakawa. We've got this giant video screen in front of that theater in the round. So you can take surgical video, you can dissect your technical maneuvers, you can really break down the anatomy. And it's a really fantastic teaching environment where you can have both the visual and the telestrated and the interactive components of the teaching. So this is an example of how, we can still innovate. We can still find new ways to connect with a tender young audience that's trying to learn this stuff. And we can convey incredible amounts of information. When you do a case like this over here, you might have a chief resident and a junior resident with you. So there are only two minds that are impacted by that case. But when you get 45 people in seats around this theater, and you share that same experience with the visual videos and everything else, it really multiplies the teaching value. Regarding that whole fading culture of traveling fellowships, this is just a slide to say that since 2006, so in under 20 years, we've had over 600 observers to the Barrow. And these are just the numbers or the neurosurgeons that we've been able to count and keep track of. I'm certain it's a whole lot larger than that when you include all the sub-interns and the medical students who might not have been recorded in our logs. But this is a huge impact. And we've always maintained an open door where people can come and spend a week, spend a month, spend a year. And it's really this incredibly valuable teaching opportunity. One of the things I'm really proud of is what I call a virtual residency. And that really has been about using social media platforms, whether it's Facebook or Instagram or YouTube, to reach a broader audience. My belief is that residents need mentors beyond their faculty. You don't always see what you want to learn within the walls of your teaching program. If somebody's not doing complicated bypasses at a particular institution and you want to learn intracranial techniques, well, what do? You need an ability to reach for a mentor beyond your faculty. And educational videos are the answer. They transcend time. They transcend travel. They transcend the freedom to do a rotation, and they're free. So we've always, since COVID, really embraced this idea of virtual residency, this idea of capturing the everyday things that we do and trying to distill them into teachable assets that we can post for free on widely accessible platforms. And that's really what my Instagram account, my Twitter account, our YouTube channels at Barrow are really focused on. And it's to get eyes on cases that might be of interest to help people learn, see things that they're not seeing, and get to be better surgeons. What's great about this as you think more deeply is that videos democratize the training experience and extend it worldwide. I have the privilege of picking from really qualified American medical graduates, and I pick four people per year and bring them into my training program. But when you think about the investment in 4 people per year, as compared to the hundreds and thousands of neurosurgeons around the world who are hungry to learn, the videos are the way to democratize the training experience. And so I'm a complete believer in that. And so ultimately, if this concept works, then virtual residency can elevate technical proficiency and excellence globally. That's really what this stands for. It's getting people to lay eyes on what we do and to broaden their minds. So some specifics, some of the previous speakers have talked about this, what can we do? And these were mentioned generally, but I wanted to try and just, be a little bit more specific. This is something that we've created as a simulator. You can see here how we build these models. We have CT scans and MRIs, which we can mix together. We have these this software that allows us to translate the imaging into 3D printed models of skulls and brains. We can generate these molds that integrate both the hard skull of the cranium and the soft brain tissue of the brain itself. And we can assemble this in ways that produce these really, really nice models. You know, they're not great for everything. A model like this may not be so great for splitting the Sylvian fissure, but it's really nice for learning how to build or cut your far lateral craniotomy and the types of or the areas anatomically that you need to remove to gain access. So this is an example of a particular type of simulator for a particular skill set, namely craniotomy. For bypass, I wanted to share this with you. This is Rokuya Tanakawa in our laboratory at the Barrow. And I wanted to show you this concept of hand tracking. So this is a computer algorithm that tracks the different digits or joints in the hand. And you can see the blue lines and the joints that are identified. And over in the corner, you can see him doing a bypass. And the idea here is that we can gather data on master surgeons like Rokuya and try and figure out what he's doing ergonomically to be so good. And when you gather this data, you know, you have to subject your surgeon to these little tasks. But when you do that, what you end up with are these profiles, these hand tracking profiles. And these are the hand tracking data. You can see this is the movements plotted over distance and space. And things start to emerge. You can see the differences in these scatter plots of how our hands and digits have moved during the case. And one thing that you'll notice that I have these tight clusters of color here, whereas Rokuya has this scatter cloud here. It's because he interrupts his sutures when he sews, and I do continuous technique. But the idea here is that you can get these metrics on how different surgeons are doing a particular task, the same task, and extract these lessons on what they're doing, how they're positioning their hands, how they're minimizing their movements, where they're actually handling the tissues and the needle and so forth. And you can then subject yourself as a learner to the same kind of hand tracking. And I think we're on a road towards developing an AI-driven coaching system that gathers data and allows you to have feedback relative to recognized experts. So if your hero is Tanakawa, you can sort of study his movements and his ergonomics. If your hero is Ghazi Yazergil, you know, you can compare yourself to that. So the AI is allowing us to get to that place. So a little bit about global neurosurgery. I think you know, one of the areas where we can improve our training environment is through helping low and middle income countries and doing global neurosurgical work abroad. This is a photograph from our Mission Brain trips to Guadalajara with Dr. Q here in the center and me here looking over his shoulder. But when we go to Mexico with Mission Brain or the Philippines with Mission Brain, and we do this work, we're able to take that sort of teaching roadshow on the road and help educate and empower neurosurgeons in environments where they don't get opportunity to see people like Q or me on a regular basis. So I think this is one way to expand or improve training, is to embrace the global neurosurgical effort. This is a picture from a trip over the summer to Tanzania. The Barrow Global Program has set up a shop in Kilimanjaro, and this just shows the work that we were doing there this summer. We've started a residency program over at KCMC, Kilimanjaro Christian Medical Center. There are residents there who are learning from not only the faculty there, Happiness Rabiel, but also with Dylan Eligala and Carrie Vaughn, who are our full-time Barrow Global faculty. And I and others go intermittently to do these training and teaching sessions, which I think are having a big impact. So these are the educational imperatives. It's to stimulate interest in cerebrovascular neurosurgery. I think this is sort of the real Cadillac cases of neurosurgery. So we have to continue that. We need to strengthen open vascular fellowships so that there are a select number of fellows that really become or gain competency in some of these complex procedures. We need novel teaching modalities like what I showed in the Eller Teaching Center. These virtual residency programs with the 7 series and the social media is really important. Simulators, I've shown you some of the state of the art, but they're particularly crude, and we've got a long way to go there to make a simulator that allows us to learn to split a Sylvian fissure, for example. Educational technology like the hand tracking analysis is really exciting. I think we're just beginning to move the needle here, and I'm really excited about where that's going. And then, of course, global neurosurgery. I think the more I go to Africa and Latin America, the more fun I'm having, the more excited I am about this, and there's just so much more to do. So there's that. I think you wanted to see a little bit of vascular neurosurgery. Let me just spend just a few minutes talking about sort of where we're at in vascular neurosurgery with a couple of cases. This is just a collection of flow diverter failures that represent sort of some of the complicated things that are happening now. More and more of these aneurysms are being treated with flow diverters, and we're beginning to see treatment failures as more and more of this work is being done. The indications may not be as sound, and we're just running into the types of lesions that fail. So I just wanted to show kind of where microsurgery remains relevant, and we can remain relevant in terms of clip reconstruction, in terms of thrombectomy and clip reconstruction, Hunterian ligation or proximal clip occlusion of these flow diverted aneurysms, and finally bypass. So just a couple of cases. This is a ruptured basilar aneurysm that was coiled. The coil mass compacted and recurred at a year. So a flow diverter was placed then, and the aneurysm regrew. You can see here the compacted coils, the flow diverters around it, and here is this case. So some of these Sylvian fissure splits require transposition of the venous anatomy, which is what you briefly saw there, but that preserves the venous connections and allows us to get in around that. That was a clinoidectomy. This here is now taking down the clinoid and exposing the aneurysm here. So we're looking here between optic nerve and carotid artery. You're going to see the use of multiple triangles. This is the carotid oculomotor triangle right here. This is the posterior clinoid. We were just in the carotid optic triangle. Here I'm taking down the posterior clinoid. I'm doing everything possible to widen these windows. There you can see the stent. You can also see how the coils are related to the stent. And now I'm just clearing perforators from the backside of the aneurysm here. And we've also got a very large PCOM right in the middle of our triangle. So this is going to be an example of what I call the picket fence technique. So I'm applying a stack of clips. The tips of the clips go right up against the flow diverter at the depths there, and the shanks of the blade squeeze the dome. And so they're right across this coil mass. The tips are right up against the stent. I'm filling each of these triangular spaces here as much as I can to create this picket fence. And you can see 5 clips now have been placed, and we've got this thing shut down. So this is an example of a clip reconstruction using every last bit of available real estate there. And here's that transposed Sylvian venous system to the sphenoparietal sinus that's been preserved. So that's just one example of a clip reconstruction technique and a full use of all the skull base adjuncts there to get there. Here's another case, a tough case that required thrombectomy and clip reconstruction. So when we look at this one, this aneurysm has really progressed despite coiling and stenting all the way almost through the midbrain, essentially dividing the midbrain into two hemi-midbrains. And you can see failure after failure of coiling, compaction, then stent placement. So for this one, he came to us from Portugal. You can see that skull base approach, taking down the clinoid, really opening up in a transcavernous sort of way, this exposure all the way down to the bottom edge of the stent. What I'm going to do for this one is apply temporary clips. I'm going to isolate the quadrifurcation between these temporary clips. So there's a clip on the trunk. Here's a clip on the P2 as it winds around the aneurysm. I'm also going to close off the superior cerebellar branches here as they come from the trunk. And then finally, reaching across to the other side, we'll get the contralateral SCA. So now the quadrifurcation is not completely isolated, but slowed down. I've got this kid on a ventricular pacing device. So if there is bleeding, I can crank up the pacing device and control or reduce the bleeding. But here I'm inside the aneurysm. I'm coussining out the thrombus around the coil mass, which converts this solid tumor into a collapsible sac. And now with that transformation of the aneurysm, we can start to apply our clips. So the walls of the aneurysm collapse. I'm able to now get this fenestrated clip across the proximal neck. So you'll see the blades going over the shoulders of the P1s and across the back of that sac. These fenestrated clips are only so long. You get 12 millimeters of blade length and the fenestration, which is another 5. So you really need a sequential stack. And you can see going toe to heel how this line of clips forms this overlapping metal closure here. And then once we get to the back end of the neck, we then have to close off this aperture into the aneurysm itself. And that reseals the aneurysm. So now the neck has been closed. We've saved the perforators. We've saved all of the trunks coming off the quadrifurcation, just inspecting here visually. And then we'll run an IC green, which will confirm that we've got good flow seen in the basilar trunk, the SCA, the PCA, contralateral SCA, all of that's filling nicely. And we've done our job. So here, after we've got the aneurysm completely closed, we can then be more aggressive with our thrombectomy. And this is the CUSA just taking out some additional mass effect. So another complicated case, here he is. He went to our rehab hospital for 2 weeks, and this is just before heading back home. So there's the before, there's the after. This thing has been completely shut down. So I don't want to take up too much time. Those are just 2 cases that just show you kind of what we can do. We can do bypass. We can do some different clip reconstructions. Here's just an overview of this experience. We've had 16 flow diverter or web or stent assisted coiling failures. You can see the numbers there for yourself. The aneurysm locations are listed here. I think the trends are that, you go usually from a coiling situation to a failure, which then escalates to a flow diverter case. If that doesn't do the job, you then refer the patient. So you often see these patients at the end of this long, protracted course, and they come really quite exhausted from this chronic therapy. But the treatments are either this clip reconstruction, as I've shown you. You can do proximal or distal occlusion, which may or may not need a bypass depending upon the collateral circulation around it. There's trapping, there's thrombectomy, and then finally, which I haven't shown you, bypass. But there are lots of different bypass options that you can use. So these are some of the hardest aneurysm cases. Flow diverter was supposed to be sort of the panacea, but this is just to make the point that doesn't always do the job. We still have to be prepared for the tough referrals. That microsurgical clipping with or without thrombectomy is, I think, the preferred option. the flow diverter will often provide you with a scaffold for you to do your reconstruction around. The bypass option is really valuable, and I save that for cases where a clip reconstruction technique is not a great one. I throw this in, I was really optimistic at one point that flow diverters might provide us with a way to thrombectomize aneurysms first treated with flow diverters, but have not found that to be the case. When I've gone into these flow diverted aneurysms, expecting them to be endothelialized and quiet, that's generally not been my experience. So that particular concept may not hold water. So I'll stop there. I threw in some training ideas there and threw in some aneurysm technical pearls. So I'm happy to address any questions you might have.
Thank you so much. That was an amazing talk. I know Dr. Saman and Dr. Sabino are here as well. Any comments or about the presentation?
I think it's fascinating. What you're doing is amazing, and it's been some time. I've been to Barrows as well, 25 years ago. So I think we all have had some taste, and it's amazing the way the whole thing has progressed and the way you have taken over. It's amazing. The other thing I must say is that there are challenges in vascular surgery when it comes to flow diverter failure, and what you showed is extraordinary. I would never dare do that, by the way. But I think it's awesome. We really enjoyed that. On education, what you're doing in Africa is great, but I think you should seriously consider other countries as well. We'll be happy to have you in different areas. We regularly visit Africa, just like you as well, for spine. So I think it's possible that we should try in other setups as well, and I'm sure you'd be happy to help as well. So yes, we will bother you. Don't worry.
Well, I appreciate the comment, and obviously, when you're thinking about how you want to spend your time on this earth, it's a finite resource, and I would love to travel more. I sometimes envision or try and envision what my retirement might look like, and I think when that day comes, it will be nice to spread myself around more. We've been Mission Brain has been really focused on Mexico because of Alfredo's particularly unique story, emigrating from Mexico and then returning to give back, and I've been privileged to be a part of that. The Tanzania story is, we as an institute really embraced global neurosurgery and just really had to choose. And Tanzania just had such a crying need. The hospital that we chose has a catchment area of 15 million patients and one neurosurgeon. So, we just felt like that was a nice place to start. But yeah, we have plans as Barrow Global to expand to other places. Our benefactor who gave us an endowment to work with, it's a $21 million endowment that we've set up as a corpus in our foundation. And that generates about $1 million a year for us to build programs. And he has a particular interest, the Frankie family, in Latin America. So our next sites will be set there, and we hope to just spread as widely and as far as we can. And appreciate the invitation to work with you.
Great job, excellent. Sabino.
Thank you, Professor, for this excellent lecture as usual. Thank you so much. Very inspiring. We just have, question from the audience, but I suppose that I saw that Professor already, replied to this question. The question was, Professor Lawton, what are your strategies for dealing with residual or recurrent aneurysm after previous clipping? But you showed two beautiful cases, so you are a living example of technical excellence. I have a comment and a small question for you. The comment is the fact that we recently in, WNS Neurosurgical Series, Giant Series, we have the opportunity to interview Professor Spetzler. And at that time, the question, it was not my question, but a friend of mine, usual question was, Professor Spetzler, what's your best advice for young generation? And Professor Spetzler replied, practice and be humble. Be humble because it's the secret, you know, for the success. And I like it so much, that kind of reply. And as a young neurosurgeon, because I'm still young, you know, Salman, don't laugh, please. But we want to ask to Professor, I try to do my best to interpret, you know, because it's obvious that for skull-base and neurovascular surgery are two different branches where the likelihood of catastrophic intraoperative complication is objectively higher than other field of neurosurgery. So how the best way to deal with fear during complex cases, especially at the beginning of the career in neurovascular surgery? This is my humble question for you, Professor, and try to do my best to interpret the questions from the audience.
Yeah, thank you for that great question. Well, I think what Dr. Spetzler said is so true. Practice, practice, practice. He would always tell us that. And humility, you know, this business makes you humble. I've done over 11,000 cases in my career, and I still have cases that don't turn out the way that I want them to. And so you can't ever get complacent or lose your humility. It was interesting. I was in Jackson Hole, Wyoming last week, and my son-in-law and my daughter convinced me, or, you know, maybe I wanted it too, I'll admit that, but I wanted to climb the Grand Teton. And it's one of those majestic things. And so they took me up, and it was funny. I watched them climb, and they were fearless. Like, they scramble across these rocks and dangle over ledges with no fear. And we had this long talk, like, what is that? And why do neurosurgeons travel to come to Barrow and watch surgery there? And I think this idea of fear is a big thing. Some people have a lot of fear in taking on these challenging cases because they're maybe not having the confidence in their skill level. Maybe they're concerned about the patient. Maybe they have a deeper relationship with that individual. There are all kinds of reasons why fear creeps into your mindset. And you know, just watching these mountaineers scramble up rocks and seeing them be fearless, and my experiencing the fear made me realize that we all have different allocations of that. You know, I don't have a lot of fear in the operating room, but I had a lot of fear on the mountain. And I think it's a matter of putting yourself in a situation where you work at overcoming that. And that's through practice, like Dr. Spetzler said. It's through skill development. It's through experience. It's through commitment, dedication, and psychology. You know, like, there are all kinds of things that generate fear, whether it's mountaineering or skiing. You know, the better you are as a downhill skier is really all about overcoming that fear of facing down a mountain. And I think it's so true in neurosurgery, is just embrace your fear, understand it, try and figure out why it is it's there, and work to get rid of it. Because when you lose it and you gain that confidence, it really is a liberating power.
Thank you, Professor. It was, you know, so stimulating and precious, all of your advices. Thank you so much once again for being here.
My pleasure.
Excellent. I think we can wrap up this. We just need Miro. Miro, are you here? Miro is, yeah.
Yeah, I'm here, Salman.
Yes, Miro, it's your time to say thank you and wrap up the session for today.
Okay. Thank you so much on behalf of the Administrative Council of WFNS. As my personal behalf, as being one of the WFNS official, I would like to thank you all. Especially thank you for Young Neurosurgeon Committee and for Salman for organizing such a beautiful, although digital event, but it was a good part of education, I think, for everybody who was attending, actually. I would like to thank all the speakers, but also all the participants. All those lectures that I have heard were excellent. I'm not going to let's say, separate individuals. Although the last speaker and the performance, that the surgery that we have seen was really something special, but everybody contributed significantly to this event. It is amazing how many people have gathered over a weekend day, when I assume some of you are still on vacation. That is wonderful. And on behalf of the WFNS Administrative Council, I can only express our gratitude and our admire to all of you for your today's contribution to this educational event that was held under the WFNS umbrella. You all have clearly shown that WFNS is in your hearts, that WFNS is something that you are care about, that WFNS with you will have a bright future. And I'm hoping that that bright future, that is bright because of young generation, that some of you will soon step into different, not only scientific activities of different, in which WFNS is actually going through, but also that you are taking active part in administrative activities that are also equally, I would say, important. And I have no doubt that some of you will be important, let's say, officers in the WFNS because you deserve it. At the end, and again, on behalf of the WFNS Administrative Council, I would like to welcome you all to Dubai in December this year, December 1st to 5th. You know that we are going to have our, let's say, largest neurosurgical gathering this year. It is our Congress. You are more than welcome. And we all are expecting you there. WFNS Administrative Council and the local hosts and the organizers are taking, let's say, huge efforts in making this conference one unforgettable gathering, both scientifically and socially. And by having said that, I would like to thank you all once again, Salman in particular, and it was really a privilege for me having few last words for this event. Thank you so much.
Thank you, Miro. Thank you, everybody. I think it's really an honor for us. If you can just switch on your pictures, your cameras, so that we can have a group photograph, please. Imad, can you do the honors, please? Everybody, please switch on your cameras. Oh, whose birthday is it?
I think that is my mistake. It's my face, but not my birthday.
Okay.
But I appreciate. Anyhow.
Okay. So is it possible, Imad, if everybody turns on their camera? Can we get everyone to switch on their camera, please? Imad, is it okay? Are you taking pictures? What?
Yes, sir. One minute. Actually, we haven't allowed everyone to switch on their camera.
Oh, yeah. Okay. So maybe allow them just for this and then switch off. It's just someone was sharing some naughty pictures.
Yeah.
Imad, if you could let them do that, please.
Don't be shy,
Yes,
guys.
now
Oh,
everyone
beautiful.
can turn on their camera.
Okay, excellent.
Okay.
And you all can smile. It's okay.
Thank you. Thank you, everyone.
Thank you, everybody. So
Thank you.
hope to see you all tomorrow, again with some excellent stuff. Thank you all.
Goodbye.
Thank you.
Bye-bye.
Thank you.
Goodbye, everyone.